the balloon. You see here the balloon is empty, and you put 600 milliliter water inside, and you have a balloon like this. It's a mechanic treatment. You reduce the quantity of treatment when you put 600 balloon, 600 milliliters liquid into the water. What is the indication really actually for this obesity patient? Just one indication, not aesthetic indication. Now in Lebanon, we use a lot of balloon just 1 week before wedding to weight loss, and we regain loss after the wedding. But the indication really of the balloon, still when you have a body mass index more than 50 and the patient need surgery, you do a balloon to reduce a little bit weight before surgery, you reduce anesthesia risk, you reduce surgical complication, and you reduce the risk of conversion on laparotomy, and the surgeon has a better visualization. It is the own and medical indication of gastric balloon. How to move the balloon? You have to introduce needles inside, emptying the liquid. We catch the balloon and remove it. What is the results of the balloon? The results of the balloon look a little bit how to catch the balloon and remove it. And our experience, because I am one of the first using the intragastric balloon, we did it just for 6 months, and only 20 to 25% of patients maintain weight loss for 24 months. Transoral gastric sleeve, just in small center we use this technique. It is interesting. It is interesting to see how does it work. I did 2 or 3 in vacuum of the mucosa. And you do a strapling. One, you continue with another stapling. It's like a really gastric sleeve, but you let your stomach in place. And to reduce intake, it is not a malabsorptive treatment, but the results is very well interesting, and you see 3 months, 6 months, 12 months after excess body mass index loss persists. What is important? Hemoglobin A1C, it is less. Triglyceride, it is less. Some complication. But it is done in a restrictive center. What is important also, this technique, endobarrier technique, it is non-absorptive technique. It is used actually for patient obese with diabetes. But look what is the technique, really interesting technique. I like this technique, it is easy, but I think that he must do in experimental center. You go with your endoscope, I don't know if you see, and you push a guide wire. You push a guide wire. You have the guide wire is going from the esophagus stomach, and this is on the barrier system. It is doing under endoscopic and fluoroscopic control, and you pass to see what happened. You push your endobarrier into the stomach, into the intestine as far as possible. It's around 1.50 meters. It is the limit, and you open it. We open it here, or in the stomach, or in the bulbus. And like this, all your nutriment pass through the devices, no absorption. It's exactly like gastric bypass. Also, the results of the technique, it's very well, but it is actually used just for diabetic patients and for diabetes with obesity. Post technique I passed because I demonstrated before what is important actually. It is Apollo technique over stitch. It is a surgery. It's important to see how does it happen. When you see it is easy to do, but you need experience, and when you do it, it is interesting. You go with the overstitch system. You put a mark where with your APC or coagulation system. It is exactly like gastric sleeve, but you let the stomach in place. It is the overstitch system. It is interesting. I like this technique. I do some operation. The problem is the cost, but we have to demonstrate what happened in the world, and you can see your stomach. You reduce the volume of your stomach. To finish my presentation with the last video, it is interesting videos. I don't know if we have a surgeon here. We have a surgeon? No surgeon? Ah, we have a surgeon. You can do this technique. It is mean we reduce the volume of the stomach. Yes, it's like gastric sleeve. But if you want to do a gastric bypass, we begin with this technique and we continue with this technique. The name is full thickness incision. Okay? We cut the wall of the stomach. I do it in my animal lab. You cut open your stomach. You go through your opening into the peritoneum. You go as far as possible that you want. You take the small bowel. You push your stent into the small bowel. This is over, the name is axios stent. You open in the small bowel the third diabolo of the stent. Deploy distal flange of the stent. Here it's open, like you see. It is a diabolo. You pull your first part or diabolo of the stent into the stomach. This is the opening of the stomach. And you release the second part of the stent into the stomach. You have the same in the stomach and the same in the small bowel. And like this, you have gastric bypass. And with this stent, because it is a small stent, you put your small bowel behind the stomach. 1 month after, it is a fistula between the stomach and between the small bowel. And like this, you can do exactly like gastric bypass. It is interesting, this technique, when you have a cancer with a complete obstruction of the stomach, you can go between the stomach and the small bowel without operation. Conclusion: endoscopy has fundamental role. Sure, before surgery, it's interesting, and it is interesting in the treatment of obese patients, and also for the management of the complication after surgery. Thank you.
Thank you so much, Professor Makur, for a very educative session.
Just one last diapositive slides. It is the better way to reduce weight. Don't eat, close your mouth. Yes.
Okay, so if there is any question from the floor?
Some question
Or
from the
comments?
surgeon?
Just the patient with BMI more than 50. You put the balloon to decrease the weight, but it is working.
Yeah.
It's working, yes.
We don't know exactly when you put the balloon. And it's same for all patients. When you put balloon, you don't know how many kilograms you must lose. Nobody knows. Sometimes you put a balloon and no weight loss. I have patients with 30 kilogram weight loss. It's dependent from patient to patient. But you must try it. You must try it. Because if he loses 10% of his weight, you reduce the risk of complication anesthesia.
This patient is prepared for surgery.
Yes, you do it before surgery because more than 50 kilogram per meter square, it is super obesity. The risk of surgery is high, anesthesia is difficult, and the surgeon don't see. Sometimes you don't have trocar to pass through the adipose wall, and it is the indication, the own indication. Aesthetic, okay, because you can put.
And you give him a chance for the 6 months? Or?
6 months. Now, if after 3 months no weight loss, you stop. It means we lost the weight more in the first part of the endoscopy, and after you maintain. But we do it systematically in all patients with body mass index more than 50.
Thank you so much, Professor Makur. A round of applause to
Yes,
Professor
surgeon. A surgeon asked a question. Yes, I like the discussions between us. Give him. I don't hear you.
Thank you, Professor, for the nice presentation. The question was about the self-explainable for reflex stents and the use of stenosis.
For stenosis.
Yeah, you say it stays for 4 to 6 weeks
Yeah.
before moving. My worry is about how often heart failure because there's chance of tissue overgrowth the stent. So to remove it becomes so difficult.
Look.
That's one.
This is what? Yes.
So second.
Yeah.
Maybe among the procedure you showed to reduce weight, which one you could comment? Probably I want to do to you. Which one?
Yes. Very good question. For the first question, of course, we try what we can to not do surgery for the complication because we know that morbidity or mortality is higher when we reopen second surgery. But never we can have 100% of success. We need you for stenosis, and we need you for fistula. We just have 10% of patients. What we do, the fistula, we cannot treat the fistula. And when, in this case, I say for the fistula, in this case, you must do a second operation and you must do your anastomosis around the fistula. This is the only treatment. Where you have the fistula, after antibiotics and preparing the patients, you must do, anastomosis just around the fistula, no treatment else than surgery. But we try to treat what we can treat by endoscopy to reduce the reoperation. The same it is for the stenosis, but we try what we can to reduce the number of surgery after the first surgery. But never we have complete success. But we are happy to have 90% of success, but 10% we always need you. This is why I said a lot of time. Gastroenterology, we must have a pool of gastroenterology, medical and surgical. We have to work always together in collaboration. We cannot do anything without you, and we cannot complete without us. I believe. Second, if you ask me which kind of operation I must do it for myself, of course, Apollo technique is still the operation with less risk of complication and with high percentage of success. Intragastric balloon, I don't put it for myself, I don't put it for my wife, but if my wife wants to put a balloon, I don't say, I try to say no, but I think no really indication, just one when the body mass index is more than 50. But I, yes, recommend to do Apollo technique over stitch technique, yes. But I say always we have to put the good indication. When we put if I have a patient with body mass index more than 50, it's not the medical treatment that it is interesting. Your place is here. It is a surgical. It's not me.
Oh, there is one question from Zoom.
I want to say something. Just Suha Rashidi, it's my head nurse in Lebanon. She is looking at us maybe now. Huh? Yes.
There is one question from Dr. Kitembo. So, Dr. Kitembo.
Hello. Yes. How are you? Fine. We don't see you, sir. Yes, Dr. Kitembo, how are you? Yeah.
I just want to know the one of the procedure for weight losing, the one you use involving fistula creation.
Yes.
What is the risk of recognizing the post-procedure?
Now look, this is just a presentation done in animal lab. But we didn't begin to do it in human. But of course, this technique need a preparation for the patients in a large antibiotic treatment. You clip you close very well your incision, and you let your patients around 4 or 5 days fasting. Like every perforation that you treat soon, you have sometimes a small perforation in everything you do. You put your patients fasting. You put large antibiotics, and you can win. Now we can do some polypectomy. So the name is full thickness polypectomy, like small guest. You cut all your guest, you open your stomach into the peritoneum and you close it by clip or macro clip, and you put your patients fasting with antibiotic for 4 or 5 days, and the incision is closed. But what I demonstrate is in my lab. It is in pig demonstration and not in to clear, not in human. Did you hear me? No. It's a really very interesting topic. It is a little bit, make a little bit time more than, but we cannot discuss it in 20 minutes. I'm sorry for the delay.
Thank you so much, Professor Makur.
Hello.
Yes.
Yeah, thank you, Professor, for such a nice elaboration.
Thank you so much, Professor. We'll be going to the fourth presentation, and this session will be by Dr. Amunga Meda. Will be taking us through an approach to the patient with diarrhea. Welcome, Dr. Amunga Meda.
Good morning. My name is Amunga Meda from Medical Gastroenterology and Hepatology unit from Muhimbili National Hospital. I'll be taking you through a brief review of updates on evaluation of a patient with chronic diarrhea. So, there has never been a consensus on what the definition of diarrhea is. In medical terms or lay person, that's the patient, non-medical patient coming to the hospital, everyone has their own definition of diarrhea. So diarrhea may be defined by, in terms of frequency of stool, that's more than 3 motions per day, or consistency of stool, volume of stool, or weight of stool. And there had been a definition of diarrhea as more than 200 grams of stool per day. And this definition was based on Western, a person who had consumed Western diet. Our Swahili diet consists of lots of fibers, and as a result, we have bulk stool, and it's not correct to classify that as diarrhea. So, patient concept of diarrhea usually focuses on the consistency of stool, and fecal consistency of stool is determined by water holding capacity of the stool. That is the amount of free water in the stool, and this is very difficult to to quantify or to measure in a clinical setting. So, according to the current British Society of Gastroenterology guideline, they recommend that quantification of this concept in clinical practice is tedious, it's difficult and impractical. So they recommend use of Bristol stool chart of stool type above 5, that's 6 and 7, to diagnose diarrhea. So, but for a more, should I say, appropriate or ideal diagnosis of diarrhea, all these concepts should be included in the evaluation of patient. So, in terms of frequency, consistency, volume, weight, and also Bristol stool chart. So this is a Bristol stool chart type 1. You have like elaborated, I'm not going to read. Type 1 and 2 is a patient with constipation. 3 and 4 is normal stool. And 5 is determined to be caused by lack of fibers in diet. And 6 and 7 is defined as diarrhea. So classification of diarrhea can be classified according to frequency, or time. So by classification, I would go with time. There is acute diarrhea that is a duration less than 14 days, and 14 days to, and this is mostly caused by infectious agents or toxins from infectious agents, and persistent diarrhea that lasts for between 14 days and 4 weeks, and diarrhea lasting longer than 4 weeks is classified as chronic diarrhea, and usually the cause is not an infectious agent. So chronic diarrhea, there are myriad of etiologies causing chronic diarrhea. We have inflammatory diarrhea, which can be infectious, that is recurrent C. diff, giardiasis, non-infectious causes such as IBD, ischemic colitis, malignance, and radiation proctitis. Colitis is cause of chronic diarrhea. We can also have osmotic diarrhea such as lactose intolerance, medications, bacterial overgrowth, celiac disease, pancreatic insufficiency, and this is due to presence of osmotically active substances in the colon, which causes water to enter the lumen by osmosis because of these non-absorbable osmotically active substances, leading to bulky watery stool. We can have secretory diarrhea because of presence of vasoactive substances, active substances in the intestine, stimulating secretion of active ions such as sodium, or inhibition of their absorption, and then causing chronic diarrhea, water diarrhea. Dysmotility, such as a patient with diabetes with autonomia, autonomic dysfunction, and other causes. So this concept of osmotic gap we'll see at the end of the presentation. So because of different causes of chronic diarrhea, classification, different presentations, and different diagnosis and management. So it's easier and practically appropriate in a clinical setting to classify patients according to nature of stool. So this could fall into one of these categories, such as blood diarrhea. This can be gross or occult, fatty diarrhea, and water diarrhea. So my presentation, I'll deal with evaluation of patients in these 3 categories. So in general evaluation of a patient with chronic diarrhea, you want to classify, to organize into 3, like I said. Additional history, you have to inquire about timing, frequency, relationship to meals, nocturnal diarrhea, which is usually associated with organic causes like IBD rather than IBS. This is a patient who is awakened at night to go and they would usually want to stay close to the bathroom so they can go frequently. Abdominal pain, weight loss, this also signifies organic cause. History of prior surgery, chemotherapy, radiation, diet of the patient, immunocompromised state such as a patient with HIV, which can be a risk factor for protozoal infections and leading to protozoal diarrhea. Laxative abuse, whether prescribed or factitious use, etc. So history of medication, there are medications which have been associated with chronic diarrhea, such as PPI, ARBs, NSAIDs, chemo drugs, caffeine, which increases GIT motility. Physical examination, you want to look at your patient in terms of weight loss, BMI estimation, signs of systemic illness, such as skin involvement, dermatological involvement in IBD, surgical scars, and rectal tone and rectal examination. Lab tests, CBC to determine anemia, metabolic profile, albumin in terms of in cases of malabsorption, thyroid function tests because of hypothyroidism, iron studies because of malabsorption, and ESR, CRP for inflammatory causes of chronic diarrhea. Imaging is appropriate, such as endoscopy, colonoscopy for biopsy to determine the causes for definitive diagnosis of causes of chronic diarrhea. Imaging when there is organic cause such as polyps or tumors and other problems that have been suspected. So blood diarrhea, this indicates inflammation and presence of blood, whether macroscopic or microscopic. Fecal WBC, lactoferrin or calprotectin, which is positive. Fecal occult blood, fever, abdominal pain. This all indicates an inflammatory cause. And as I said, there are many causes. You can have infectious causes such as chronic C. diff, Ectoamoeba histolytica, Yersinia, CMV, TB, especially in immunocompromised hosts such as HIV patient. C. diff is also known to be a notorious cause of exacerbation of IBD. You can have inflammatory bowel disease such as Crohn's and ulcerative colitis. History of radiation can cause radiation enteritis, ischemic colitis, neoplasia such as colon CA, and lymphomas. Also segmental colitis associated with diverticular disease. All of these can cause inflammatory diarrhea. So infection is common, especially in sub-Saharan Africa, so you need to rule out infectious causes by sending through 3 stool samples, fresh samples, and ovine parasites and culture and sensitivity. Sometimes you need to do modified techniques such as modified ZN stain for protozoa infection, especially in immunocompromised hosts for Cryptosporidiasis, Isospora, Microspora, etc. In chronic blood diarrhea workup, like I said, colon biopsy is a mainstay of diagnosis because this will help you to help distinguish between IBD and other infections. Infections, pseudomembranes such as C. diff and Shiga toxin producing E. coli. Viral inclusion such as HCV, CMV in patients with on immunosuppressant drugs such as solid organ transplant like liver and kidney. Parasites such as amoeba, schistosomiasis, and tuberculosis. It's important to differentiate between tuberculosis and Crohn's disease because both involve ileocecal portion of the bowel, and management are different, and if one mistaken for the other, this could lead to dire consequences to the patient's outcome. So if it's not bloody, then it's fatty. And there are many causes of fatty diarrhea. This is called steatorrhea. And fatty diarrhea can be caused by either malabsorption or maldigestion. So there are luminal causes of fat malabsorption and mucosal causes of malabsorption. Luminal causes of maldigestion and luminal causes mucosal causes of malabsorption. So malabsorption, usually the stool is fat, increased fecal fat, and increased osmotic gap, but diarrhea decreases with fasting, especially avoidance of fatty foods. So there are mucosal defects, defective mucosal absorption of nutrients because of changes in mucosal surface, such as surgical resection, mucosal disease such as celiac disease, IBD, and this presents sometimes with bloating, foul smelling, and floating stool. And dietary history is important, and relation of diet with the diarrhea, like I said. Weight loss is important because there will be malabsorption of nutrients leading to malnutrition. And then stool history and examination of stool. Not you always stool will be watery, but can be hard to flush, and oil droplets floating in the toilet bowl. So there are other clinical presentations that such as malabsorption of fat soluble vitamins. So patients with long-standing chronic diarrhea might present with osteomalacia due to vitamin D and calcium malabsorption metabolism, night blindness, and easy breathing, and vitamin E deficiency. According to British Society of Gastroenterology, it's very important early on to rule out treatable causes such as celiac disease. So celiac disease, I'm not going to discuss the specifics, but there are antibodies to test for, such as tissue transglutaminase antibody and the endomysial antibody. You should do the donor biopsy to confirm for blunted villi atrophy, Crick's hyperplasia, but may not be necessary when serology is positive. So treatment is gluten-free diet, and when patients are not responding, there is issues with compliance, or should look for an alternative diagnosis. Fat diarrhea, there could be also due to small intestinal bowel overgrowth, and this is following a patient with abnormal anatomy, such as surgical manipulation of your cerebral valve, causing colonic bacteria influx into the small bowel and growth of overgrowth of bacteria. This can, because it's a malabsorptive condition, you can have B12 deficiency because bacteria will consume B12, but will produce folate, so there might be an increase in folate. There might be protein-losing enteropathy and others. So the cause for intestinal bacterial overgrowth should be sought. It's very interesting that you need other techniques for diagnosis of small bowel bacterial overgrowth, such as aspiration of duodenal content, but due to contamination, the guidelines recommend empirical treatment with antibiotics, and when patient improves, then the diagnosis is probable. There are other causes of fat diarrhea, such as short bowel syndrome from extensive bowel resection. You can have maldigestion, and this is due to defective intraluminal hydrolysis of nutrients, such as a patient with obstructive jaundice and reduced bile salts flow into the small intestine, or pancreatic insufficiency in patient with chronic pancreatitis, pancreatic tumor, etc. So you can do some tests such as fecal fat estimation, but most of these tests are obsolete, so you can do fecal elastase test, and normally it's less than 200 grams is diagnostic. But also trial of pancreatic replacement therapy, enzyme replacement therapy with positive response can be diagnostic. So, like I said, fecal fat, you can do qualitative such as Sudan 3 fat testing. Normally, you should see less than 20 fat drops per high power field, or you can do quantitative 24 hours, which is tedious, and normally fat content should be less than 7 grams per 24 hours. The next step should be to radiological imaging, such as CT scan, to rule out organic causes of diarrhea. So if it's not blood, it's not fat, then it should be watery. And the causes of watery diarrhea are numerous, and this could be categorized into secretory forms and osmotic forms. So osmotic forms, like I said, is caused by non-absorbable food substance and digested fermentable food substances. In the acronym FODMAPs, this is fermentable oligo, mono, disaccharides, and polyols. Some patients, some diabetic patients are given sweeteners as a substitute for sugar, and these are not absorbed, so they are osmotically active and might cause diarrhea, osmotic diarrhea. So all of these are as causes of osmotic diarrhea. Osmotic diarrhea also decreases with fasting because the presence of these non-absorbable food substances are osmotically active. But secretory diarrhea, which is caused sometimes by medications, microscopic colitis, bile acid-induced diarrhea. This is presence of excessive bile acid in the colon. All of these can cause secretory diarrhea because of inhibition of absorption of ions or excessive secretions of ions in the colon lumen. So water diarrhea can also present in patients with diabetes, and causes should be sought after. This includes bacterial overgrowth, celiac disease, pancreatic insufficiency, unabsorbed sugars, such as, like I said, but also the commonest is the visceral autonomic neuropathy as a cause of chronic diarrhea in patients with diabetes mellitus. So this is an algorithm from British Society of Gastroenterologists guidelines of 2019, and they recommend that once you see the patient, the first thing to do is primary clinical assessment, and this should include evaluation of patient for malabsorption such as celiac serology, iron deficiency, CRP, thyroid to rule out inflammatory causes, and stool examination to rule out inflammatory causes or infectious causes. And then you should rule out, the second point is to rule out presence of life-threatening conditions such as inflammation or cancer, and colorectal cancer or IBD should be suspected, and colonoscopy with biopsy should be taken to rule out these life-threatening conditions which can be intervened early. And then after that, you should, when celiac disease is suspected, upper GI endoscopy with biopsy should be taken to evaluate for these causes. Other small bowel IBD, you can use MRI enterography, capsule endoscopy, and CT if MRI is not present. So once you've ruled out these, the second step should be to consider functional causes of diarrhea, such as diarrhea predominant IBS, and then a specialist review for other causes of diarrhea. But in our setting, the structure of healthcare in Tanzania, specialist will be the one to see all of these patients. So secondary clinical assessment should assess for malabsorption, such as iron deficiency, B12, folate, rule out mucosal malabsorption. Assess for immunodeficiency. This should be, in our setting, this is done immediately in contact with the patient, chronic diarrhea, because HIV is predominant is endemic in our setting, to rule out immunosuppression as a cause of chronic diarrhea. And then assess for common disorders such as bile acid diarrhea, microscopic colitis, which patients should undergo colonoscopy and biopsy, even if normal colonoscopy. And this could be lymphocytic or collagenous microscopic colitis. And then lactose malabsorption suspected, you should do hydrogen breath test, and post-radiation diarrhea, which is easy to get from patient history, and colonoscopy if there has been a history of treatment with radiation. So in terms of malabsorption, fat malabsorption should be suspected and pancreatic imaging should be done. They recommend MRI and not CT scan, but only when CT should be done only when MRI is not available, and fecal elastase to test for pancreatic insufficiency. All other tests for pancreas, such as pancreatic enzymes, are non-specific and for diagnosis of chronic pancreatitis. There are surgical disorders which could cause chronic diarrhea, such as fecal incontinence or impaction and overflow incontinence. MRI or CT should be of the pelvis should be done with contrast to rule out fistula and other causes. Other rare causes of secretory diarrhea are hormone secreting tumors such as lipoma, gastrinomas, and these should be evaluated late because they are uncommon with hormonal assays. So in summary, this is the summary of workup of a patient with chronic diarrhea. So chronic diarrhea could present as blood diarrhea, which indicates inflammatory, and blood diarrhea could be gross blood or WBC in stool or occult blood. And then this should be inflammatory conditions such as infections and IBD should be suspected. So stool culture and colonoscopy with biopsy are important to evaluate for this category of patient. Patient with fecal malabsorption, malabsorption or maldigestion should be suspected. Patient with fecal fat, positive fecal fat, and based on history, tissue transglutaminase, antibodies, stool elastase, carbon 14 hydrogen breath test, or upper endoscopy with biopsy, and sometimes endoscopic ultrasound to look for these tumors that are important. Otherwise, patient with watery diarrhea, you should be able to categorize as secretory or osmotic, because this will lead you into specific etiologies for each of these. So an important concept is to do stool osmotic gap by measuring stool osmolarity, which is above 290, about 290 minus 2 times stool sodium plus stool potassium. So when the difference is less than 100, usually less than 50, this indicates that these ions have been secreted excessively in stool, so the difference is small, and you should suspect secretory or functional causes. So CT scan, colonoscopy, and hormone levels for this category of patients. And patients with osmolarity above 100, usually cutoff points are above 125. Think of osmotic diarrhea from non-absorbable osmotically active substances in the colon, and this should be, like I mentioned, will help you narrow down all causes of osmotic diarrhea. This marks the end of the presentation. Thank you.
of applause to Dr. Amunga for a very educative session. So I'm welcoming the floor. If there are any comments and questions. People from Zoom, you are all welcome. But please kindly type that you have a question before you start to speak, because we get sound interference between our mic and your mic, and it becomes noisy. There is no any question from Zoom. So if there's any comment. Thank you so much, Dr. Amunga Meda. Now we'll go to the last presenter for the morning session, for the first morning session. And the presentation that we have we're supposed to have a Zoom session with Dr. Jaka from Bugando, but we are still working if she can pop up to present. So for the time being, let's go for break. We are taking break for tea. And we will only do this for, we are lagging behind time, so it will be 20 minutes. And so we'll be back at 11 sharp, and we'll be starting the second session. Thank you. So our panelists for this session will be Dr. Ngwana Sai, medical gastroenterologist from Aga Khan Hospital. Dr. Ngwana Sai will be one of our panelists. Professor Makur will be another panelist.
I am always a panelist. Yes, no.
We all agree you're always a panelist, but this time around we'll move you from that chair to that chair, but with the same title. Yeah.
It's better from here.
Yeah.
No, no.
Later, yes, okay. So without wasting any time, may I welcome Dr. Igembe Nkandala to start his presentation. Welcome, Doctor.
So thank you. So I'm going to give some few updates on inflammatory bowel disease, and I'm supposed to use 20 minutes, so I think I'll finish in the prescribed 20 minutes. So I'll tell you briefly the methodology of the updates that I've come up with, and then discuss the updates on epidemiology, a bit of diagnosis, complications, imaging, treatment, and surgery, as well as follow-up. So I searched through the PubMed website for the changes since the last meeting, because the last meeting was 2 years ago. So almost everything I'm going to discuss is being based on the changes in the past 2 years since we last met. So obviously I cannot discuss everything because there were 1,000 results. So I just picked a few which I thought they were important. So similarly, if you look through the Google Scholar for the past 2 years since the last targets meeting, there are about 18,000 results. So we cannot discuss everything there. So the first update is on the epidemiology, and this is the paper that was published 2 years ago on the epidemiology of inflammatory bowel disease in sub-Saharan Africa. And you can see Tanzania, there's only been one publication, this was in 1977. So in a way, this is not an update. So just the information that we need to update ourselves on the epidemiology. And I think there are efforts to clarify the epidemiology by the multi-center registry, which I think you are probably familiar. Yeah, but I think we need to come up with the latest information on what is latest about the epidemiology. By contrast, our colleagues in Egypt, they have a publication this year on the inflammatory bowel disease. Although this is a single center experience, but what they notice is that their trend of inflammatory bowel disease is increasing from a period of 2008 to 2010. So they are probably better than us, so we need to have some data. The other update that I've come across with, and this is also this year, published in the Annals of Clinical and Translational Neurology, is that patients who have multiple sclerosis have a higher risk of developing inflammatory bowel disease, as well as vice versa. So therefore, we can consider this part of the history, maybe, and consider that there's a coexisting neurological disease. With regard to imaging, there's a development of new imaging for patients who have inflammatory bowel disease. So this one is to, it was a pilot study to look at the feasibility of magnetic resonance elastography in the assessment of stenotic Crohn's disease. So sometimes it's difficult to differentiate between inflammatory Crohn's disease as compared to stenotic Crohn's disease. So in this pilot study, they were able to show that you can use MRI to show that patients who have IBD, the stiffness of the intestinal wall is actually higher compared to patients who are healthy. So this was comparison between healthy 20 patients and patients with IBD, specifically Crohn's disease, with a few patients who also had ulcerative colitis, but the predominant population was of Crohn's disease. So maybe in the future, we can be using MRI as well to differentiate between inflammatory, between stenotic disease and non-stenotic disease. The other update I'll talk about is the endoscopy. So there's no significant guideline updates regarding endoscopy specifically. So the only thing that has been published this year is the performance measures for colonoscopy in inflammatory bowel disease, and this is by the ESG. And what they're recommending is that we need to have these performance measures. So for instance, for procedure, then we have to document the rate of reported indication for colonoscopy, and then the rate of photo documentation. I think in most hospitals, this is a big problem. We don't photo document colonoscopies. And then I think the other important issue for us as endoscopists is that in suspected IBD, the objective is not sequel intubation. So if you're suspecting inflammatory bowel disease, your intubation rate should be high. So this is not like the screening colonoscopy for colorectal cancer. So we need to improve on intubation as well. Maybe the other thing I would say is the assessment of endoscopic activity. The other study that I came across, published in the past 2 years, is that the sigmoidoscopy is not a good tool to assessing response, because now people are going towards mucosal healing. And for mucosal healing, it's recommended to do the total colonoscopy. So you are going to get about 20% less lesion if you're doing only rectal biopsy as compared to if you do the total colonoscopy. So the recommendation is to go to assess the whole colon to really detect mucosal healing. And then I'm going to move to treatment. So again, this is last year, and as you are familiar, the guidelines actually do not recommend stopping treatment, but this was a systematic review with meta-analysis looking at the effects of withdrawal of immunomodulator biological therapy. So what is important is that if you have Crohn's disease, you can see that if you stop treatment, the likelihood of flare is about 2 times. This is in contrast with the ulcerative colitis, whereby if you stop treatment, then there's no higher likelihood of a flare. So this is not, there's no new recommendation regarding stopping treatment, but I think considering the expenses, considering the side effects, we probably can consider in patients who have ulcerative colitis to carefully stop treatment. But in patients with Crohn's disease, the likelihood of a recurrence is statistically significant. So this was this systematic review consisted of about 500 patients, and it involved about 10 randomized controlled trials. I think we have had several patients who had required infliximab in the past, and again, this is last year. So this is the trial to look at whether you can give infliximab subcutaneously as compared to intravenously. And when you see CTP113, this means this is a biosimilar. So a biosimilar is by contrast to the brand drug. So this one is cheaper, and it also reduces the cost because the dose for sub-Q injection is even lower compared to the IV medication. So in this case, the randomized patients to receive IV or subcutaneous biosimilar for infliximab, And so the dose for IV was the one that we usually use, that is 5 mg per kg. And for sub-Q, they use 120. For a person who was less than 80 kg, and they use double dose for people who are above 80 kgs. So the first objective of the trial was to look at the pharmacokinetics, and you can see that the serum concentration, so this is a sub-Q, by the way. The red is the sub-Q, and the blue is the intravenous. So when they look at the pharmacokinetics, what they found that you actually achieve a higher concentration of infliximab, even up to 44 weeks of treatment. So this gives us another option of using biosimilar, which I think will be cheaper at a lesser dose in patients who are having resistance to the immunomodulators. Regarding the hard clinical points, which we usually are interested with, so if you look at the clinical response rate at week 2 up to week 54, there's almost no significant difference, and the same is true for achieving clinical response. So this is a partial response, and this is the total clinical response. So at the end of 54 weeks, the difference was not statistically significant. So they concluded that sub-Q biosimilar for infliximab is non-inferior to IV biosimilar. So this is for Crohn's disease. The previous picture was for ulcerative colitis. So this was for ulcerative colitis, and this is for Crohn's disease, and the information is the same. So the other thing that has been published this year is the use of antibiotics in patients who are using anti-TNF alphas. So this was a study that was a follow-up study that was done in Israel, and they look whether different types of antibiotics influence the development of anti-drug antibody formation. As you know, when you're using anti-TNF, with exception maybe of adalimumab and others, you lose the response usually because of the anti-drug antibodies. So what they found out is that if you're using cephalosporins, then the likelihood. So the yellow is those who have used cephalosporins, and these are patients who have not used cephalosporins. So the likelihood of developing anti-drug antibodies is higher when the patient has used cephalosporins. By contrast, patients who have used fluoroquinolones and the macrolides, the likelihood of developing anti-drug antibodies are lower. And therefore, this is something else to consider when you're using monoclonal antibodies. We might think about considering macrolides and fluoroquinolones as the preferential antibiotics, so as to reduce the loss of efficacy of the antibodies. So this is just to summarize that the hazard ratio for developing of anti-drug antibodies is higher. So it's about 2 times for cephalosporins and about 1.5 times for penicillins, while for fluoroquinolones and macrolides, they are protective with regard to development of anti-drug antibodies. So the other challenge is the patients who do not respond to monoclonal antibodies. So this again was an exploratory study to look at whether you can combine. And the information that we see here, they've tried combining adalimumab with vedolizumab, golimumab and vedolizumab, adalimumab with ustekinumab. But overall, what the study shows is that when you try to combine, you are going to get a response in only a third of patients. So, but considering that these patients were also non-responsive in the first place, they say that this is probably also significant. So given that we don't have a lot of alternatives, you can consider there's different combinations. So the study is a small one, but there's no combination that seems to be superior compared to the others. So you can try with whatever you have, and you can get a response in about 30% of your difficult to treat patients. So I will not talk about this guideline, I'll just talk about the changes in the guideline. So this is a guideline that was also published this year. And maybe the main change that has been brought up in this guideline is that there's no evidence to support the use of methotrexate for the maintenance of the remission. So in this year's guideline, they've removed methotrexate as a maintenance treatment for the remission of an ulcerative colitis. I'll talk briefly about surgery. So there is no change in any guidelines regarding surgery over the past 2 years, but I will just tell you the previous guideline because my personal experience is that it's difficult sometimes to understand each other with surgeons. So this is not really an update, but just to remind you, according to this guideline that was published in 2015, so it's best, especially for hospitalized patients, that patients should be cared by a joint team of gastroenterologist and a colorectal surgeon, so, or even a general surgeon. And the other thing, I think we have seen some patients who die because they do not receive thromboprophylaxis. So I just wanted to remind you that patients who have severe colitis, usually they are at higher risk of DVT and thromboembolism. So just to remind you, even when they are bleeding, you should not hesitate because this is a prophylaxis. It's not a therapeutic anticoagulation. So you may see them bleeding from the GI, but they are still at high risk for embolism. And the other thing which is extremely difficult when sometimes we talk with the surgeons is that they insist we continue with medical therapy at week 1, week 2, week 3. So this is just to re-emphasize that if there's no improvement within 7 days of the first line and the second line treatment, it's very unlikely that this patient is going to respond to medical therapy. So you reassess after 3 days, and then you reassess at 7 days. If there is no response, then please, surgeons, it's no longer a medical case. So in this case, it's a surgical case for colectomy. Maybe something else to add here is that if you can choose to delay the surgery while withdrawing treatment, because the perioperative use of steroids is associated with worse surgical outcomes. So you can stop corticosteroids, and if the patient is not deteriorating, to allow for removal of the steroids from the body, and then you can do your colectomy. But if the patient is deteriorating, then it's best to go in earlier rather than later. An update on complications. So just one complication. So this was a retrospective cohort of data to look at the occurrence of urinary complications. And what I wanted to emphasize is that the rate of urolithiasis is high, and it occurs both in Crohn's disease as well as an ulcerative colitis. So I think in the past, what we were told is that urinary stones are more common with Crohn's disease. But I think, so this now shows even patients with ulcerative colitis, they are at high risk for renal stones. So therefore, not all abdominal pain, that's an update, not all abdominal pain in inflammatory bowel disease is because of the bowel. So it could be originated from the urinary system as well because of the higher risk. A bit of update on monitoring. So this was a registry looking at monocytosis as a biomarker of severity of inflammation in bowel disease, and it looked at 6 years. And so patients who were having monocytosis, they were at higher risk for emergency room visits, and this applies for Crohn's disease as well as ulcerative colitis. they are also at higher risk for hospitalization, and this applies for both. So for us with our limited biomarkers, therefore we can consider using monocytosis, which is present in about a third of patients, as a predictor of difficult to treat ulcerative colitis as well as Crohn's disease. So you can prioritize your treatment as well, maybe going with the biologicals if available, or even with immunomodulators very early. So patients with monocytosis are also at higher risk for surgery for both Crohn's disease and ulcerative colitis. So this again can be used to predict the outcome that you are going to deal with. Thank you very much. My 20 minutes are up.
Yes. Thank you so much, Dr. Igembe. Another round of applause to Dr. Igembe.
Yes, Dr. Nobi, an interesting presentation. And you are better than me because you respect the time. I didn't respect the time. It's interesting for the staging, the endoscopic control in case of ulcerative colitis. It means you have patients with high risk of developing colorectal cancer with rectocolitis. It is in young patients. When you do your first endoscopy, it is pancolitis and colorectal history of cancer. For these patients, it is interesting to make complete exam of colon. It is mean not just normal coloscopy. You must do NBI colonoscopy or chromoendoscopy technique to search the small lesions, because this patient is with a high risk to develop colorectal cancer at 15 years after the first diagnosis. Young patients, when you do your first exam and you see pancolitis, and patients with history of colorectal cancer and polyp, I would like to push in this direction, because prevention is a little better technique actually. Your presentation is complete. Somebody has a question for doctor, or you have some comment?
Yes. Thank you, Dr. Igembe, for a very insightful presentation. Yeah, it was really short and concise. But I just want to comment about when to stop treatment. Usually it is difficult to make a decision on when to stop treatment, especially in Crohn's disease. But even in ulcerative colitis, you have to be careful. Once this patient has a recurrent bleeding, it may be difficult if there are recurrent flares. Then it may be difficult to stop. But if the patient has come to you with first initial symptoms, you are starting treatment maybe for 6 months or after a year, and you are thinking that they are doing well, you probably turn around and stop. But once they have at least 2 different flares, then it is difficult to make that decision. That's what I wanted to comment. And I think, again, it is a very good update that now we should not consider reflexive for the ulcerative colitis. Thank you. Maybe any other questions?
Yeah, thank you, Dr. Igembe, for a nice presentation. I just have a question on what is your experience in terms of the medicine availability? Why I'm saying so is because I don't know if it's the issue of awareness. Recently, we got a little bit of challenge in terms of getting the medicine. Of course, even mescaline was a big challenge, leave alone the mono infliximab, which is easier getting a cannabis compared to getting this medication. But also, I would really wish to encourage, if we can roll this ball in terms of awareness of the IBD, because in the bad experience I had like 3-4 months ago, I had a child who came to my attention after 2 years of suffering IBD and not getting appropriate treatment, doing twice colonoscopy and with biopsy confirming ulcerative colitis, but then there was no person to proper explain and follow up the patient. So by the time reaching to me was in catastrophic phase. The child was just 11 years, girl. Yeah, so there was very little we could do until after like almost 5 to 7 days later. That's when I was already in failure, I was about blood and all these issues. So I wish to encourage if we can really create more awareness. Even the point you said about the thromboprophylaxis, even with that child, we had a lot of argument with the pediatrician, was really against putting the prophylaxis with the same justification the patient's passing blood stool. So why should we do this? We had a lot of chat, and it wasn't easy to convince, because also it wasn't the time for educative moment, because we had the problem at stake. So
okay, thank you very much.
Anyone else wants to ask? All right, so we'll continue.
So for the sake of time, we'll have all the presentation for this session, then we'll have discussion at the end. So may we acknowledge the presence of Professor Reda, Professor Abdel Wahab, and Professor Mohammed Kamal Shakar. Thank you so much. Okay, Dr. Gembe received your compliment from Dr. Godfrey Njele for nice presentation. So the next presentation is by our president, Dr. Waldo Komba. He will be taking us through complications from endoscopy, how to avoid them, and how to manage if they occur. Welcome, Dr. Komba.
Thank you very much, Madam Chair. Our theme for this year's conference is about the role of endoscopy in treatment and management. Endoscopy has been so good, both in diagnosis and treatment. Many people have benefited from it, but it is not without some complications. In the next few minutes, I'm just going to highlight some of the complications and stimulate some discussion about how we can actually go around these complications and avoid them altogether. Because there are so many techniques in endoscopy, so many forms of endoscopy, for 20 minutes we cannot discuss all of them. I decided to choose these two. One, I'll discuss on the cardiopulmonary and sedation-related complications in endoscopy. And the second one would be complications which are specific to the diagnostic and the therapeutic upper gastrointestinal endoscopy. So if we start with the cardiopulmonary and sedation-related complications, if a patient undergoing endoscopy gets complications, about 50% of morbidity caused comes from these cardiopulmonary and sedation-related. And if they die, 50% of the causes of this death are actually because of the cardiopulmonary and the sedation related. And most often it is because of a direct or indirect consequence of either an elderly or a frail patient or at-risk patient being given unnecessarily high dose of sedation, both benzodiazepines and opioid. And these days, of course, we are using propofol. Maybe we're going to discuss what are the challenges and the risks of propofol. And my colleagues at Muimbili will also share with us if we have ever experienced any complications with the propofol. So if you look at the upper gastrointestinal endoscopy, both diagnostic and therapeutic, this is now for the diagnostic and therapeutic, there are so many cardiopulmonary and sedation-related complications. Oversedation is one of them. Drug-induced respiratory depression, aspiration pneumonia, some cardiac arrhythmias, hypotension, even angina and myocardial infarction, stroke, nausea and vomiting. All these are related to cardiopulmonary and sedation effects. So if we discuss one complication after the other, starting with the oversedation resulting into either deep sedation or even general anesthesia, how can we go about and reduce this? Usually, during diagnostic endoscopies, we tend to give conscious sedation, which is nowadays called moderate sedation and analgesia, and we are using these benzodiazepines and opioid. We want this patient to be able to communicate, to be easily rousable, but sometimes they go into deep sedation, over-sedated. So how would you do to actually avoid the complications of deep sedation? Usually you have to stimulate this patient, both verbally and if necessary by light shaking, so that the patient opens eyes and you encourage them to take in deep breath several times. This will prevent going into deep sedation and the complications that can come about. If we look at the drug-induced respiratory depression, those that will agree with me, we are not now these days using the benzodiazepines and the opioids. We have actually moved into propofol, but in other centers still these medicines are used. So these drugs, benzodiazepines and the opioids, can cause both hypoxemia and carbon dioxide retention by hypoventilation. So to recognize these complications, there are several ways, but I'm told the most sensitive way of detecting hypoxemia and carbon dioxide retention is by the use of continuous capnography. I don't think if we have it here, this one will pick deoxygenation as well as will pick the hypoventilation. Pulse oximetry is very good in picking deoxygenation, but cannot tell you there is hypoventilation, and therefore, once you deoxygenate, it is too late. The hypoventilation started earlier, so someone can go into serious complications. Clinical assessment during the procedure and the patient is sedated is a very poor way of assessing that, so that is not very much relied upon. But if you see cyanosis and reduced ventilatory effort, that is a little bit too late. So do we have these machines? Do we have continuous capnography? Maybe at our center, Muimbili, we don't. So management, again, you may need to reverse the sedation by flumazenil, or if it is opioid, you might need to give naloxone to reverse the effect of medication. One of the common complications is aspiration pneumonia, and usually this occurs in patients who are obtunded, who have actually impaired level of consciousness. And to know if your patient is aspirating, they can react during the procedure, maybe by coughing violently. They can become cyanotic, and evidence of deoxygenation using your pulse oximeter. But if you have capnography, that's much better. Usually when you see that, as you usually do, suctioning the oral cavity and throat is very important. And then you have to give the supplemental oxygen. And if the patient had the impaired level of consciousness, you might need to reverse or make the patient regain that level of consciousness. You encourage them to cough A chest X-ray would be very important because you are suspecting aspiration to see if there are any pulmonary lesions. And these patients must be covered with the antibiotics, and chest physiotherapy would be important. And one of the things many of us forget during endoscopy after the procedure is the monitoring. You have to monitor for some time. Cardiac arrhythmias is another complication, cardiopulmonary and sedation related. These ones are quite common, but fortunately, they are not very much clinically significant. However, ventricular tachycardia and ventricular fibrillation have occurred in the past, causing death. And usually, these may cause complications during or after the endoscopy. So there's this issue of monitoring, continuous ECG monitoring. You should be monitored. Is it everyone? But the suggestion is this should be done in at-risk patients with the relevant cardiac history. But another comment is when you are using propofol as your sedation. Now, I think this one will be discussed again. Here at Wimbili, maybe we don't do the continuous ECG monitoring at times, but it is important as a risk. Hypertension, hypotension, and vasovagal fainting. These can occur through various ways. During colonoscopy and appendoscopy, sometimes there is a sympathetic stimulation of the patient, and they can develop hypertension. So to avoid the adverse effects of very high blood pressure or very low blood pressure, patients should be actually assessed very well. Relevant medical history and drug history has to be taken. Antihypertensives, anti-angina, and antiarrhythmic drugs have to be assessed very well, and you should also assess the timing of the last dose the patient took. It is very important to measure the blood pressure in the past, before, during, and after endoscopy to see if these patients have any alterations. And if you see a dangerously high blood pressure or low blood pressure, you have to defer the endoscopic procedure and resuscitate the patient so that they come to normal vitals. So, angina and myocardial infarction have also occurred, one of the complications. And again, it has been noted in studies that they can occur even after the procedure. You have done your procedure, you think your patient is well. After 5 hours, 7 hours, the patient is home, develops the myocardial infarction. So to prevent those complications, those at-risk patients, you have to pre-oxygenate them before the procedure and give them supplemental oxygen when you sedate them, and make sure you leave them on their antihypertensives, their own, so that the blood pressure is within normal. Though this can sometimes lower the blood pressure further during the procedure, you have to monitor. Some patients would develop angina during endoscopy. In that case, you must be having in your emergency medicine box, the sublingual GTN and oxygen should be given to the patient. Of course, the ECG is an important one to see if they have gone into ischemic complications. Some patients may get cerebrovascular accidents and changes in blood pressure, hypertension, hypotension, cardiac arrhythmias, and if they had a myocardial infarction, this can even complicate into cerebrovascular attacks. These ones have to be assessed before you scope your patient. So to prevent that one, you have to make sure that you avoid the extreme changes in blood pressures. Nausea and vomiting has been a common complication in endoscopy. One of the most common causes is opioids, and sometimes when you train your patient during ERCP or colonoscopy, you can actually you can stimulate the vestibular receptors and induce the vomiting. But during a colonoscopy, again, the over-distension of the colonic loops during colonoscopy, you can also induce vomiting. So to prevent these ones, you have really to minimize the use of these opioids. You have to have a vomit bowl always in your room. Sometimes we are not prepared and someone is vomiting, you do not have that one. Rarely you might be forced to use antiemetics like IV, metoclopramide. And to prevent that during colonoscopy, just check your technique. Make sure that you don't insufflate excessively and you don't form loops unnecessarily so that you reduce the chances. Some patients may get reaction or side effects from anticholinergic drugs. In ERSP, sometimes we are using Buscopan. Buscopan has anticholinergic effects that can cause a number of issues, including palpitations, mydriasis, constipation, and difficulty voiding. So suppose you're doing a procedure on an old man with prosthetic symptoms, you might cause urinary retention, or those patients with the closed angle glaucoma, you can complicate that one. So one of alternatives to these anticholinergic drugs is the use of IV glucagon. It can be an alternative. And among the opioids, it's surprising, pethidine has anticholinergic effects, but other opioids have cholinergic effects, so they are different. So pethidine is also, you have to be careful when you're using pethidine. So those are some of the complications, cardiopulmonary and sedation related. Coming to gastrointestinal complications of upper GI endoscopy, these are several, but my outline, I will discuss first what are these complications, then I will discuss a little bit very few complications related to specific therapeutic techniques, and then I shall discuss a little bit on how do we recognize these complications, how do we manage them and prevent them, and lastly, my conclusions. So, usually during endoscopy, there are minor problems like discomfort in the abdomen, that's okay. Cardiorespiratory complications, I've already said. But there's this issue of infection. During endoscopy, it's easy to transmit infection, either from patient to patient or patient to staff. But also, some patients come to endoscopy, have risk for endocarditis, infective endocarditis. They should be given appropriate antibiotics. And some of the infections we are so much concerned with transmission of viral hepatitis and HIV during endoscopy. We have discussed about aspiration pneumonia, which is also a risk. And sometimes during difficult intubation, retropharyngeal abscesses and retroesophageal abscesses have formed, giving the patients serious problems. So infection should be prevented, and we shall see how we can avoid that one. Another complications of upper, that is diagnostic endoscopy, is bleeding. Usually bleeding is a rare complication, except if the patient has coagulopathy or has thrombocytopenia. You can do endoscopy safely even when the platelets are at 20,000, but below that one is a risk. Or some patients with portal hypertension are also at risk, but if you don't have those, then the risk of bleeding is not that high. Now, how about the use scoping a patient who is on anticoagulants at therapeutic dose? Studies have shown that the risk is not that high. You can do and take those pitch biopsies safely. Even those ones who are on aspirin and other NSAIDs, the risk is not very high when we are doing diagnostic endoscopy. So these ones you don't have to stop, but some experts do stop these NSAIDs and anticoagulation some days before they do the endoscopy. Perforation is another possible complication of diagnostic endoscopy, but you can see the rate, the frequency of perforation is 0.03% in good hands, and the mortality is 0.001. So you can see relatively low, but if it occurs, it's a serious complication. We have to prevent it. So the risk factors for perforation include strictures, malignant obstruction, some osteophytes, and pharyngeal pouches. And that's why we insist when you scope the patient, you have to have a direct visualization so that you see where you go. If there's a pouch, you can go blindly and cause complication. So here you can see some images here under the diaphragm. This is a perforation of the viscus, and this is massive pneumoperitoneum. This is a result of perforation during examination. So if we look at now complications which relate directly to the specific therapeutic procedures in endoscopy, if we start with esophageal dilatation, common complications are either perforation, pulmonary aspiration, and bleeding as I discussed earlier. During esophageal dilatation, we do it in our centers, especially at Mumbili. If you are doing it in good hands, the rate of perforation is 2 to 3%, not very high. Mortality of 1%, it does occur. But benign stricture dilatation is associated with the lesser events of perforation compared to dilatation of malignant stricture. These days, when we put stents in patients with esophageal cancer, we tend to dilate with the bougies. You can see there is a relatively higher risk, so we have to be careful. In achalasia, if you want to dilate, the risk is up to 70%, in the mortality up to 1%, so it's even easier to perforate in achalasia. And the perforation rate increases when someone is inexperienced, in the elderly, when you have a complex stricture and large dilator. I was actually curious. Suppose a patient from Western Road has done radiation of esophageal cancer and you want to put a stent. Is there an increased risk? Studies say no, the risk is the same with someone without exposure to radiation. How about when you place stents, esophageal stents, for relief of obstructive symptoms? Stent placement is associated with a number of complications. Up to 20 to 40% of patients who are stented can go into complication mortality of up to 3%. Now, perforation is the most common when you put plastic stents, but with the self-expanding metal stents, the perforation rate is a little bit less. And I think in our center we use mainly the SEMS, not the plastic stents in malignant stricture. But other complications of stent placement, hemorrhage usually is a late complication. Stent migration, especially when you have distal strictures, the stent can go into the stomach. Tumor ingrowth these days is less because of the covered stents, but tumor overgrowth, it can occur up to 20% of the patients, both distal and the proximal ends. We have seen patients who are coming with food bolus obstruction after stenting. It's quite common, up to 15%. And remember, many patients with the lower strictures, they get the gastroesophageal reflux, and it can be very troublesome, even causing some serious cough. When you are doing hemostatic techniques to control bleeding, sometimes you also get complications. So what are the complications when you are doing the non-variceal hemorrhage hemostatic techniques? We know we have 3 groups of methods to control bleeding. Injection with the adrenaline, 1 in 10,000, thermal techniques, and mechanical techniques. With injection of adrenaline, the complications are quite less. But when it comes to the thermal techniques, multipolar and bipolar coagulation, the perforation rate is up to 2%. And remember, if you are using the monopolar electrocoagulation and laser treatment as a thermal method to control bleeding, these are associated with the higher risk. So these days, they are not actually promoted. You better use multipolar or bipolar techniques. When you go to mechanical hemostatic techniques, these ones, we have the clips. Clips are quite good. The only complication is sometimes you cannot accurately position the clip, and then you fail the treatment, bleeding continues. Otherwise, it's a safe mechanism. With the variceal hemorrhage hemostatic techniques, we have the band ligation and sclerotherapy. Sclerotherapy is associated with so many complications, and the most serious ones including transmural inflammation leading to mediastinitis, pleural effusion, perforation, or stricturing up to 20%, portal vein thrombosis, and other serious complications. And this has been used for many years for variceal bleeding, but these days many people are actually going for band ligation therapy. And you can see the complications, mainly superficial serrations, but very rare. It's very rarely it complicates with the perforation or stricture formation, and a very low mortality. And I think in your center, I don't think if we have we are doing sclerotherapy except for gastric varices when we use the tissue adhesive. We have done several procedures in our center using the tissue adhesives, the histoacryl. Maybe we have not experienced complications, or some patients have got complications outside our hands because we don't admit them. But possible complications include embolization. The glue can go to the distant organs, sometimes fistula formation, or sometimes the glue cast can extrude, and that can cause very serious bleeding. We have seen some cases where the injection needle is stuck to the valix, and then the removal of it from that valix is a little bit difficult. You can even cause some bleeding, and sometimes you can even damage the working channel of your scope. These are some of the complications. When it comes to polypectomy and the endoscopic mucosal resection, we say if you see a polyp in the upper GI more than 5 millimeters, that one has to be removed. And the best way to remove is through polypectomy or EMR. Complications, perforation in the hemorrhage can occur up to 2%, but these ones can be controlled in the usual manner as I described earlier. For endoscopic mucosal resection, bleeding can occur up to 17%, depending on the definition of bleeding. Perforation can also occur, but the management is really the same. And here's just some pictures to show after EMR there was a small perforation. This was managed with the application of clips. But remember, if you perforate an intestine, a senior surgeon has to be informed if you want to manage conservatively, and this patient must be followed up very closely in case some complications develop. Ablative techniques also can cause some complications. Laser therapy, photodynamic therapy, and argon plasma coagulation, all these are used to treat pre-malignant and early malignant disease of the GI. But laser therapy and photodynamic therapy are associated with serious complications at high rates. Argon plasma coagulation of the three is a little bit more friendly with fewer complications because it acts superficially. The burning, the effect is superficially on the mucosa, and therefore we are using it sometimes for controlling bleeding, and by itself causing bleeding is rare because that bleeding can be controlled by itself. But some of the complications, abdominal distension because of gases, you can control it by sucking. Some patients can develop stricture formation. Removal of foreign body, this was discussed yesterday. I'm going to discuss it. Now, to recognize a complication, you have done your procedure endoscopy, you want to see whether or not you have come out safely. So one of the things is make sure that as you are drawing your scope, you withdrawing your scope, assess the mucosa very well and see if there are complications. But there are some signs that can come if you have caused a complication, especially perforation. You can see many signs including subcutaneous emphysema. You can palpate around the neck. If you see that one, you should know that you have perforated around the cervical region. For intrathoracic and intra-abdominal perforations, these ones we have immediate, we have early and late. For immediate signs, you will see some hemodynamic changes, oxygen desaturation, which you can see it visually. For early signs of perforation within 24 hours, you can see all these other signs, including subcutaneous emphysema, pneumothorax or hydropneumothorax or peritonitis. But sometimes the complications come very late. And with the late complications after perforation, fever will develop, sepsis, abscess formation, fistula formation, and other changes. Now, if you see all this, you should know that there is a possibility of perforation. And what we do, we need prompt investigation and of course management. So what we do, you have to endoscopically assess the area of possible perforation, and the chest X-ray here is very important. You will see air, maybe under the diaphragm. But if that is not recognized and it is now an early or late perforation, then you have to do a contrast study, water-soluble contrast swallow, to see extravasation of that contrast. If that does not give you any sign, dilute barium swallow is a possibility to use. But sometimes CT scan can actually replace the barium studies, and you can see the evidence of perforation. To recognize hemorrhage, that is, I think, straightforward, because the patient can get features of upper GI bleeding with hematemesis or melena and the hemodynamic instability. Now, the management with perforation. If it is a cervical perforation with a small instrument and the perforation is small, that can be managed conservatively, but a surgeon must be informed in case of any complication. But if there is a cervical abscess, then that must be drained because it can spread into the mediastinum. So if you want to do a conservative management, you have to exclude all these risks. If the perforation is detected early and prior to oral alimentation, that can be an indication to try manage conservative management. If the patient doesn't have shock or systemic sepsis, if there's only moderate fever and leukocytosis, if pain can be controlled easily, no these serious complications like crepitus, hydropneumothorax, pneumoperitoneum, and others. These are the criteria to assess in your patient before you decide conservative management. Otherwise, surgical management must be done. And these are absolute indications for surgical management when you have perforated. If the patient is unstable clinically with shock and sepsis, if the mediastinum or peritoneum is contaminated, or if you have done a barium study or an X-ray study and there is widespread extravasation of contrast, or there is luminal obstruction or retained foreign body and there is perforation, you must go to surgery. Or you tried medical therapy and it failed, you have to go for surgical management. If you perforate in malignant disease in the esophagus, we talked about placing the stents, the cells. That one will be very good. Managing bleeding complications, as I said, you can use the adrenaline, you can use the mechanical method, you can use the thermal methods. But sometimes you try all these three, they fail, then radiological intervention radiology comes in for managing the bleeding, and actually sometimes you don't even see where the bleeding is. You can use this technique to find one. Surgical intervention has a place in bleeding that is not controlled. This was a bleeding ulcer here, and an attempt to inject with adrenaline was done, and then you can see the clips have been placed. Still there was oozing, then the hemospray, these days we have hemospray, was applied here to control the bleeding. So these are techniques of controlling hemorrhage. So generally, to prevent these endoscopic complications, we have to adhere to some rules. One, in order to avoid them, have a good patient selection. And in this case, assess the comorbidities before you scope your patient. And if there are any, take care of them. The second thing is appropriate patient preparation. In that case, if the patient has comorbidities, improve them before you attempt an endoscope. And if the patient has a contaminated abdomen, the stomach, for example, has GOO, you may even need to do lavage. Or that's what patients who have normal stomach, fasting is enough to clear the contents. And the other thing, let us go back to the orthodox medicine, whereby if you want to do endoscopy, you must first be familiar with the techniques and equipment, but we must be having established protocols. I don't know, Dr. Eva, if we have established protocols at our unit that we should always follow before we do our endoscopes, but the procedure should be performed by trained personnel. But if a student is doing it, then it should be really closely supervised The ED yesterday said the trainees are destroying scopes that we build, but this is the point. We have to supervise them closely. And then we have to recognize the complications promptly, and we should accept. There are some cases whereby someone caused a perforation and did not want to report, did not even inform the patient, and this is a medical legal issue. We have to accept the perforation as occurred, and you have to manage easily. Monitoring during recovery, I think this is an area where we need to invest more. After you have finished your endoscopy, please, you have to monitor. And therefore, the nursing staff and the patient should be aware of these early manifestations of complications, and they should know what to do when they occur. Then high index of suspicion is quite important. So in conclusion, we say although we are using the national portals and not needing to cross tissue planes to gain access into the GI, endoscopy is invasive of the human body, and so there are some risks and complications associated. The cardiopulmonary and sedation-related complications are surprisingly high. The potential benefits for therapeutic endoscopy must be weighed against the risks so as to prevent these complications. And many complications in endoscopy are actually preventable. So there are some simple and relatively simple precautions that can be applied and that can prevent a number of complications. Thanks.
Yes, Dr. Kumba, thank you for your complete presentation. It is a big topic. We can discuss it in different parts. Is there some question before?
Professor Makur?
Yes.
I'm sorry. We agreed to do them at the end of the session.
Yes, no problem.
All right, thank you. So a round of applause to our president and our teacher, Dr. Komba, for a very nice presentation. Okay, our next presenter for today is Dr. Saringo Sangeti. Saningo. Dr. Saningo Sangeti. Professor Reda, can you pronounce Saningo Sangeti?
Saningo.
Saningo Sangeti. Yes. Now you're African. Now you're Tanzanian. Thank you so much.
Good afternoon, everyone. I will take you through screening colonoscopy, and particularly I will have a short discussion on the role of artificial intelligence. And of course, this is the area where there is a rapid research which is ongoing, and we cannot really say to be very new because people have started researching it since 2003. And so saying it's new is not really, but probably the development is the one which is not, which is coming so fast. So the interest here is on the detection of colorectal cancer. And what we are saying is, this is the tumor, of course, which is very common and is the third commonest. And if you look at the statistic of the death which are caused by cancer, then the tumor count number 4. But it is one of the tumor which can be prevented. And this can be done only through early detection and probably resection of the precancerous lesion. Now, we have been doing the colonoscopies, and colonoscopies are actually the gold standards when it comes to detection of this lesion, but also it may help us in terms of resection. The only problem is that detection, the effectiveness of the colonoscopy depends on certain qualities. And one of the quality is the adenoma detection rate. And very unfortunate, the adenoma detection rate varies from endoscopist. And you can see some of the endoscopists have very low detection rate, and some have got a very high detection rate. Now, what does that one translate to? For those who are having very low detection rate, then it's likely that they are going to miss some adenomas, which are probably going to be precancerous lesion. As the result of that, basically it's recommended that at least all endoscopists should target to have adenoma detection rate of above 25%. Now, if you look at some studies, the meta-analysis of about 15,000 colonoscopy, it has been realized that actually about 26% of cases of adenoma are actually missed. And this now may translate into a suboptimal examination, and in most cases is may result into interval cancers. And of course, these interval cancers are responsible for about 8.6% of all colorectal cancer. So it's very important that, if possible, adenoma should be detected early. So why that one is important? Because any increase in adenoma detection rate, then it is inversely related to the colorectal cancer, especially the interval one, by 3%. And also, it really helped to reduce mortality of those interval colorectal cancer by 5%. So if we improve our way of detecting this adenoma, then the likelihood that probably we might prevent so many cases that would have been not prevented is possible. Now, the challenge is whether we are able to increase our detection rate from those who are having very low, at least to a 25%, which is recommended. Basically, there are several ways that have been seen to improve the adenoma detection rate. And one of it include the experience of the endoscopist himself, but training is very important, and the techniques employed by the endoscopist, and now the computer-assisted diagnosis is being studied and has been trying to be validated to see how it can standardize the practice of different endoscopists. So if we look at the experience of endoscopists, it appears that one needs to do so many colonoscopies in order to perform a quality colonoscopy. And of course, some studies are recommending at least 150 and above colonoscopy, but others are actually recommending 230. The most important thing here is that you need to perform the colonoscopy continuously. If you perform it and leave it, again, that experience is lost. So the stability is maintained by continuous practice. But again, there are some studies that have been performed, one of the systematic review and the meta-analysis that included 3 trials and 119 endoscopists. In fact, what have been detected is that training intervention is associated with a trend toward increased adenoma detection rate, with odd ratio of 1.16. But again, if the training is provided, some of the RCT have been performed, especially in centers, and this RCT included 40 colonoscopy screening centers with suboptimal performance. And it was grouped into two groups. The one which feedback was only given, but also the other one which actually had a structured training in which assessment, hands-on training, and post-training feedback was provided. And in fact, what was seen is that those who were given a structured training had actually an improved early and late detection of adenoma compared to the other one. And there is a sustained ability to keep on detection of the adenomas. And therefore, training actually accounts for a very important part when it comes to adenoma detection. Techniques, again, is very important because if one rush, then it's likely going to miss some adenomas. But again, if the mucosa is not well exposed, probably, or if there is no good preparation, then it's likely that one is going to miss so much of the adenoma. But the other thing is that the addition of devices that will help endoscopists, especially those who have a low detection rate, to detect adenomas. And this is the place where the artificial intelligence comes. And in fact, technology have been built on, and the computer somehow have been trained to mimic a human brain. And this training has been done by feeding up the computer with certain information. And at the end of the day, the computer do some analysis and predict probably the characteristic of the lesion, or probably detect the presence of that lesion during the colonoscopy. And in fact, it will provide you a real-time optical diagnosis, and at the same time, it might predict the histology lesion. Therefore, help you to know whether the lesion need to be probably resected and discarded, or probably you might need to take a further action. So the computer aid diagnosis, in fact, has got two modes, the detection mode, but also the characterization mode. So during the procedure, especially for the detection mode, when you are doing the colonoscopy, and you arrive to an area where there is an adenoma, the computer will help you to know that the adenoma is there before even visualization by probably giving you a beep sound. But it will demonstrate visually by putting a cycle or a box of which will be able to visualize and say probably the lesion is at a particular site. So some studies have been done to try to see the effectiveness of this computer aid diagnosis. And what has been found is that when it is compared colonoscopy without it or with artificial intelligence, adenoma and polyps detection rate actually increases. This is a meta-analysis as well involving 6 studies, all of them. If you look at the risk ratio of the detection of adenoma is above 1, and it's in favor of the use of artificial intelligence. So some of the challenges when one is doing colonoscopy is for the detection of the flat or depressed polyps. And of course, some studies have been performed as well. And what has been seen is that with the combination of linked color imaging then the sensitivity of the computer-aided diagnosis is quite high, and it provides a sensitivity of 100% and a false positive framework of 0.01%. So when you are doing this kind of endoscopy with artificial intelligence, in fact, the system will help as well to characterize the lesion. And probably it will group the lesion into those which are neoplastic and those which are not neoplastic. And again, this can be demonstrated by a green color when you see a lesion. And probably this include a hyperplastic one and the sessile serrated. And when a yellow color display on the side, this one indicate the presence of the adenoma and the cancer are included. And therefore, when you are doing it, you can detect the presence, but at the same time, there is a possibility that you can identify whether you are dealing with a pre-malignant or not. So why this characterization is important? It is very important because if you look at this system, in fact, it has been designed to detect diminutive polyps. And most of these diminutive polyps are benign. So you need to characterize to know whether you are dealing with something which is pre-malignant, malignant, or not. Otherwise, you might increase the cost of doing polypectomy unnecessarily. So some studies have been to validate the characterization mode, and what have been found is that there is a quite high agreement between the histology and artificial intelligence-based surveillance, which is approximately 94.4%. But it's good to note on this that even pathologists, sometimes you give them a tissue to examine, and there is no 100% agreement between them. And reassessment can always give you a different result. So we really think that after a validation of this tool in a well kind of studies, probably we expect that increased adenoma detection rate will increase, but also it may help us in terms of quality assurance, and it's likely that you are going to get a real-time feedback. When some endoscopist was asked about probably whether this system is destructive and sometimes misleading, many of them agreed that it is not. But some studies are really saying that, of course, sometimes it might take away the attention of the endoscopist, because when you hear a beep and there is a display of color, you might leave other areas to examine and concentrate on that area. So probably it has got some weakness as well. So this is what I was saying, that endoscopists grade it as user-friendly, it's not distracting, and not time wasting. But of course, the beeping sound somehow might distract the clinician in practice. So the false positive is one of the weakness, and the artifacts from the bowel content, mucosal wall, are responsible for this false positive. Probably in our part, we have got a challenge when it comes to patient preparation, and probably it might cause a lot of artifacts. So, as we said, most of data for the tumors, for the polyps, adenomas which are less than 5%, less than 5 millimeter in size, and therefore data might be under representation for the advanced tumor, scars, sessile, serrated tumor, and also non-granular lateral spreading tumors. So the conclusion from this is that with colonoscopy alone, probably without experience, then adenoma miss rate is quite high. And in fact, this one will likely lead to a high colorectal rate in the future. And different studies has recommended that to improve this detection rate of the adenoma, training is quite important, but clinician techniques, experience, and the artificial intelligence. And of course, we are saying that the computer-assisted diagnosis is really promising endoscopy tool to increase both detection and accurate characterization of the lesion. But in fact, validations of studies, organization of big studies involving different population with different characteristics probably is very important at validating this kind of computer-assisted diagnosis. Otherwise, if we rely few data, the issues related to medical legal might come in because the computer is likely going to give you what you fed it in. So something that has not been fed in is unlikely to be reported. So it might miss something which is very crucial, or it might tell you the presence of something which is not accurate, and if you take a step, then the likelihood that you might end up with some legal issues might ensue. So with that one, thank you so much. That slide wind up my presentation.
Thank you so much, Dr. Sangeti. Another round of applause to Dr. Sangeti for a very educating session. Now I'm handing the mic to our panelists, Professor Makori and Dr. Mwanasai. Please welcome. So this discussion will be for...
We can begin discussion now, yes?
Yes, yes. Yes.
Okay, there's some question before our doctors. We have to say thank you, Dr. Sangeti, for your presentation. It was an interesting presentation also. Is there a question? Everybody say that the presentation was wonderful and no question. Some reflection. I don't have question, but some reflection. Of course, about using glucagon is interesting thing. You have to pay attention for diabetes. First, if your patient has diabetes problem, the problem of glucagon it's expensive. Compared to Buscopan, because we use sometimes glucagon when you do ERCP sphincterotomy, and we have difficult to stop extraction with Buscopan. Of course, about anticoagulant when you have a high risk of bleeding. For polypectomy, you must stop anti-aggregan, antiplatelets, and aspirin also. Of course, for ERCP sphincterotomy, you can do it with aspirin, but you must stop the other anticoagulant. It is important to do the balance between the indication of anticoagulant for patients and the side effect for your intervention. I have something to say also about esophageal perforation. Of course, one of the treatment I discussed in the morning using double technique, clip and stent. The problem of the stent, you must use totally cover stent with high risk of migration. We have a technique for those who are using, you can put first partially covered stent. The problem of partially covered stent is the migration, the growth of the tissue into the metallic part of the stent. And with this, you have difficult to remove your stent after, because it is a benign lesions and you don't need to let. After this, after 4 weeks, you can put in the stent partially stent, totally covered, partially covered stent. You put totally covered stent the same size and the same length. What happened? This totally covered stent can destroy the mucosa, grows into the partial part of the stent, and 4 weeks later you can remove the two stents together. It is an interesting technique to treat our patients endoscopically, not surgery. The surgeons look, we have a lot of technique. Just one thing also, because I have some reflection, interesting, doctor stated, when you have a bleeding in the stomach or everywhere, you must have combined technique. It's better than single technique. Combined technique, it is mean, inject liquid with a little bit adrenaline to stop the bleeding. Before the treatment of bleeding, you have to stop it, because you go inside into the stomach, you have a lot of blood and you don't see anything. You have to inject around the lesions, and you inject in 4 places with mechanical pressure, not adrenaline. You know, the adrenaline, half time of adrenaline is about 2 minutes. It's not the adrenaline to stop the bleeding. What's stopping the bleeding? It's the bulging of the water that you inject around. And after this, your bleeding is stopped, and you must keep it. And if not, you don't have it here, you cannot stop your bleeding before sending your patients to radiology or to surgery. We have in different centers the nano powder treatment that the American Army uses for skin bleeding. This is not a treatment. This powder stop the bleeding. You repeat your endoscopy the second day. It is a bridge to treat endoscopically your patient and to not send it to radiologists and to surgeon. And we say sometimes 2 or 3% of patients we need radiology intervention or surgery. It's for you. Just some 2 comments for screening. It's interesting what you say, but artificial intelligence, it's far to be in use actually in different centers. I said it before, you must take minimum 6 minutes to remove, to put your endoscope. It is interesting. You must have a good preparation. It is interesting. And what you say, it is interesting when you are in the cecum. Always try to do retrovision into the cecum, because if you have one polyp in the hepatic flexure, you cannot see it when you pull on your endoscope, and you cannot see it when you push and when you pull. And you must have, it is a recommendation to insufflate the cecum, to try to do retrovision into the cecum, to come back and to see the hepatic flexure. It is a place with a high risk of polyp. It's finished. Thank you.
Thank you so much. Thank you, Prof. Yeah, mine were some comments. I think he has made most of the comments for Dr. Koma. Yeah, mine were about about the adenoma detection rate. I think this one has been established in the West, where the incidence of colorectal cancer is very high. So I would think that it would be important to establish our own local standard, because our incidence of colorectal cancer is lower, although it has a trend now increasing. increasing over time. So probably our standard may be 10% or lower, because I think in a population of 100,000, I think our incidence is about 5 instead of 50, I think, in Europe. So I think that one is a question to think about. Yeah, he has talked about the withdrawal time. Yeah, otherwise I was thinking about increasing polyp detection. I think there is another technology of using over-scope accessories. You can put something over the scope that flaps out when you are withdrawing. I think Prof. experience with this.
Yes.
Yes, which would be probably cheaper, because maybe it will take time for us to have the artificial intelligence.
Yes, you can deploy. You can open your colon when you come back. This is like a flash. Yes, yes, you have something
like this, and it is not expensive. It's easier to see when you come back. You have sometimes the polyps after the fall, and these are around maybe 2 or 3 euro or US dollar piece. It's not expensive.
So the other thing I wanted to say is that it is important for all of us to classify our polyps with various classification.
Just something interesting thing, the risk of perforation with diverticulum, and when you have stenosis after inflammatory diverticulum is high. When you arrive to the regions of the diverticulum, if you have difficulty to pass, don't try to do the impossible. Stop your endoscopy by colonoscope and go with gastroscope. You reduce the risk of perforation. And sometimes you have the diverticulum in the left, in the sigmoid. And if your exam take the time with insufflation, the air passes through the stenosis and you have a perforation into the cecum. You are working into the sigmoid and you have perforation into the cecum. Don't do the impossible. You cannot pass after 5 minutes. You try your gastroscope, you cannot pass, you stop your exam and you do CT scan or otherwise complete your intervention. Our complication, it is the perforation of the colon because it is really important complication with fecal peritonitis, operation in emergency. Don't do the impossible. We have our limit and we have to respect.
So I just wanted to get your experience in your unit in terms of sedation. Here we have actually switched to using propofol, and in other places they're using midazolam and opioids. What is your experience and what would you maybe advise us on the use of propofol?
Yes, this is an interesting question. To do a good exam, you must have all the facilities. I am the head of 2 departments, one in Belgium and one in Lebanon. We do all our endoscopy with propofol, or gastroscopy, colonoscopy, ESD, EMI. I think we don't need it for gastroscopy. I agree with you, but I think never do colonoscopy or ERCP without propofol, because the patient is quiet, you are working easily, the risk of complication is really less when your patient is under complete sedation.
I think about acute diverticulitis still. In acute cases still, I think we have to wait to do colonoscopy. I mean, we don't have to do yes, when it is acutely infected, we have to wait maybe 4 weeks, 6 weeks.
Of course, it's interesting. The discussion is sometimes more interesting than presentation. No, really, I like discussion because we give a message. Our role it is to give a message, not for us, for young. Of course, contraindicated to do colonoscopy in case of diverticulitis. Contraindication. Diverticulitis is a risk of spontaneous perforation without air. One. Second, you must stay minimum 1 month after finishing antibiotics. Third, if you have CO2 insufflation when you are working on difficult area, it is really better than working with air. I give these three information.
I can add another comment to decrease the complications of colonoscopy. Don't try to do colonoscopy with active bleeding below. It will be difficult to find a lesion. It may be because the heart, the blood will get on the tip of the colonoscope and prevents vision. So it's better to wait for 1 or 2 days till the active bleeding stops.
Just one, it's interesting also.
If you have a machine to give water, if you have difficulty to pass ambulation or diverticulum, don't use air, just push, give water, because you have what's the mind? How to say? The weight of the water. Just the weight of the water and the insufflation of the water can open in front of you you can see better the lumen, and like this you can success and also reduce the risk of complication and perforation. Thank you, Ms. That's a lot of time.
Professor Reda. There is one comment from Zoom by Dr. Godfrey Mchele, with a certified gastroenterologist. It's saying, just to add, previously we used to believe segmental resection is contraindicated for inflammatory bowel disease, but of recent, if you have access to evaluation of the whole colon, and if you have spared the colon that looms healthy, you can resect the affected area and execute primary anastomosis.
No, in which indication? In Crohn's or in rectocolitis? It's interesting to tell us. In Crohn's disease, we have indication for treatment, and in rectocolitis, we have different indication of treatment. I don't know if we hear us. For rectocolitis, we don't agree to do partial resection definitively. In the Crohn's, I say yes, not in rectocolitis.
Thank you, Professor Makura. Dr. Mchele has got your concern and your right.
What?
I hope Dr. Mchele will have something to add on that.
Yeah, okay.
And we will update you once you have
Yeah.
that. So, we are going to the third session of the day. And the session... Oh yes, Dr. Mchele.
Yeah, I'm very happy to organize the presentation that thank you, Professor, for the acts that you are putting into this. But regarding the exceptions, I understand that most patients with severe colitis at once they have a risk of having colitis this baby. The risk is that will not after 8 years for the additional process. And at times when this patient presents with a tumor, people used to be hesitant to stay with the tumor as other colon and the tumor coming up to normal. So they used to have a lot of problem. And the family has to be lost. And that was my comment for the day for that. And that being the case, if you have tumor in colitis, it's now
Mchere, can you hold on for a minute? We are connecting with the speaker so that everyone can hear you. People at the back.
He can write his answer on the chair.
Yes, because
We have the speaker today, Professor.
No, he can write his comments on the chair. Answers, reply on the chair.
tell him that we didn't hear him very well.
Let's put the speaker first, and then you will be, I think it will be shorter in time.
Okay.
Than timing.
Please, can you repeat your question?
Comment. Yes, it's comment. Comment is replying to your answer of his first comment. Commenting.
Can you recommend, please?
Can you hear us?
Hello?
Okay.
Yes.
Yeah.
Yes, 1 minute. Hi, Dr. Chair. Hello?
Yes, I can hear you.
Yes.
Where should I start?
Yes, now you can
Start all over.
You can start all over.
All over from the beginning?
Yes, please.
Because we didn't hear you. Can
All
you
right.
repeat? Can you repeat?
I started by thanking everyone who presented, and I can see how well organized this thing is. And of course, I liked so much the comments from the professor. But my ad was clarification, basically clarification on the section that I was talking about. Can you hear me well?
Very well.
Can you hear me?
Yes, yes.
Very clear. We can hear you clearly.
Yeah. So, we all understand that patients with ulcerative colitis, with time, they present with a high risk of developing colorectal tumors. And basically the risk adds up more after like 8 years to 10 years from the initial diagnosis. So these are the patients need a close follow-up as high-risk patients by that time. But this patient, when they develop a colorectal tumor on the grounds of ulcerative colitis, most of the time we used to believe this patient deserves to have a total proctocolectomy with a permanent end ileostomy. But you understand the quality of life with the patient with a permanent end ileostomy has a lot of challenges. So I was saying of recent, we have seen that if the patient has a good access of evaluating the whole colon, apart from the tumor at a certain segment, and if so, the mucosa looks healthy and okay on the rest of the colon, this patient can still have a peritoneal resection like any other patient with colorectal tumors. Then this patient will proceed with a normal follow-up post-colonic tumor section. So, hello?
Yes, we hear you.
Yeah. And talking of, I also tried to talk about the Crohn's disease. So, Crohn's disease, we understand patients present with skin lesions which can affect the GI anywhere from the mouth to the anus. So, unless there are new developments, from my understanding, we tend to be skeptical on accepting lesions from Crohn's disease because we try to avoid to have repeated serial resections that will end up with a short bowel syndrome to the patient. So that was my comment.
Yes, okay. Just I answer you about rectocolitis. You know, you can make actually segmental colectomy, and tomorrow maybe your patients increase on rectocolitis. The recommendation actually, if we must do operation on rectocolitis, is total colectomy, independent from the side effect and the age of the patients. It is our recommendation, and we discussed it also with our professor here. For rectocolitis, no indication for us, and for recommendation, no indication for segmental colectomy. We must go for total colectomy. Thank you for your comment, doctor, and we must move for the second session. Thank you very much.
He is on air, but he doesn't know that we can hear his family discussion.
Thank you very much. Thank you very much for steering the discussion. Thank you, Professor Makoro. Thank you, Dr. Chen, and everyone who participated. So we are marching to the fourth session of the day. And in this session, we're going to have three lectures from this session. And the first lecture will be by Dr. William Lutege on behalf of Dr. Ali Mwanga. Dr. William Lutege is the surgical gastroenterologist. He will be presenting to us on pancreatic cysts. Why are they important? Welcome, Dr. Lutege. Okay, as Dr. Lutege will be sending his presentation in the computer, Dr. Chen has risen a concern that he couldn't get well your comment, Professor. So maybe you should repeat it as we are fixing the slides. Dr. Chele did not hear your reply on his comment. Can you repeat?
Hello. Did you hear us? Yes? After discussion with the expert here, the recommendation, we ask always about recommendation. The recommendation in case of indication of segmental resection independent from the indication. In case of rectocolitis, the recommendation is to do total colectomy. Yes. Hello? Yes, you hear me? It's finished? Total colectomy is a must. Yes. Yes, total colectomy, not segmental colectomy. You don't have to believe. We have to say the recommendation, international recommendation. The indication is total colectomy, iliorectal anastomosis, independent from the side effect and the age of the patient. You agree, Dr. Rida?
Yes. Totally agree.
So that's what I would say.
Yes.
So I still believe that
Okay, everybody heard you. Thank you, doctor. Okay, we move to the last session. It is his own experience and opinion, but we think for the audience, I don't put my own indication. What I do, what we do every day, it is international recommendation. The guidelines for everything that you don't know what you have to do, you go for guidelines and you practice the guidelines what you have.
Thank you, Professor Makul and Dr. Michele. So welcome, Dr. Michele, to the
On behalf of Dr. Mwanga, I'll be presenting this topic, pancreatic cysts. Why are they important? And this is the outline of the talk. Pancreatic cyst lesions, these are heterogeneous group of lesions from single multiple cavity, forming neoplasia to non-neoplastic tumors. They comprise a clinically challenging entity, and their behavior they range from benign to malignant disease. And the correct management of this lesion may prevent progression to pancreatic cancer and minimize the need of lifelong screening and their related costs. It is often difficult to differentiate these various types of pancreatic cystic lesions. And because of improved imaging, the prevalence of this on the modality of investigation used, but with high incidence on MRI studies. So this is the WHO classification of pancreatic cystic lesions. The most common is the non-epithelial, non-neoplastic cyst. These are pancreatitis-associated pseudocysts, followed by the epithelial neoplastic cyst. We are going to talk of the epithelial neoplastic cyst because they have been confused with the non-epithelial, non-neoplastic cyst with bad outcome. So for this session, we will cover some of the epithelial non-neoplastic pancreatic system. The first, that is the most common, in the interductal papillary mucinous neoplasia. It arises from pancreatic duct or its side branches, characterized by mucin-producing epithelia, and often demonstrate papillary architecture. And it's commonly located on the pancreatic head, and some they may be located on the body tail, and 5 to 10% they can be diffuse, involving the whole pancreatic organs. They are classified into main duct, branch duct, and a mixed type. But main duct interductal papillary mucinous is associated with invasive carcinoma in about 40%, while the branched duct is associated with invasive in less than 10%. And they have different histology. One of the histology is gastric, intestinal, pancreaticobiliary, and oncocytic. And these histological types of this, they express different mucin, and this they can be used for diagnosis. For example, for those who attempt using endoscopic ultrasound with fine needle aspiration and analysis of the cystic fluid. And this different type of histology, they are associated with different type of invasive carcinoma. And these are imaging, these are MRI study of the interductal papillary mucinous. This is the branched duct interpapillary mucinous neoplastic, which is grape-like dilatation of side branches. This is a diffuse dilatation of the main pancreatic duct, which is the main duct IPMN, and this is a segmental dilatation it's a segmental involvement, but this is the side branches, and these are ERCP image, but ERCP image is not recommended as the use of diagnostic for this pancreatic cystic lesion because it's a low sensitivity and the associated complication of the ERCP. The second commonest pancreatic cystic lesion is the mucinous cystic neoplasia, which occur exclusively in women, and more than 90% they are located in the body. And you need two histological criteria for diagnosing this mucinous cystic neoplasia. One is the mucinous epithelium and the ovarian-like stroma. But the mucinous cystic neoplasia, they are associated with invasive carcinoma in 8 to 30%. This is the cellular cystic neoplasia. It can occur in any part of the pancreas, and usually they are single, but if they are associated with some hereditary syndrome like von Hippel-Lindau syndrome, they can be multiple, and they are characterized by microcystic cellular appearance, but they have 3 histological morphology. And with this, they do not communicate with the pancreatic duct. And rarely, a few cases of malignancy has been reported with this cystic lesion. Another is the solid pseudopapillary neoplasia, but evaluation of this cystic lesion, many guidelines they recommend during investigation and evaluation, you have to assess high-risk stigmatas and worrisome features. Apart from high risk, you have to evaluate those patients with symptomatic cyst, or when the cystic is more than 1 centimeter, and for those with cysts that they are less than 1 centimeter, you need only surveillance. And these are the imaging that they are recommended for evaluating this patient. The MRI with MRI-CT is the first recommendation, followed by the CT scan as an alternative investigation to the MRI. Endoscopic ultrasound is recommended for those patients with worrisome features, as we shall see. These are the high-risk features for malignance. Those patients who present with obstructive jaundice, enhanced solid component within the cyst, and if the main pancreatic duct is dilated more than 10 millimeter. These are the patients who they have a high risk of malignant, and the recommendation is to proceed with surgery. And if there is those features of high risk stigmatas, you have to assess for features of worrisome features. These are features of pancreatitis, or if the cyst is more than 3 centimeter, thickened enhanced cystic wall, or the main pancreatic duct is 5 to 9 millimeter, or non-enhancing neural node, or lymphadenectomy. These are the patients that they are indicated to undergo endoscopic ultrasound. And endoscopic ultrasound has a lot of advantage regarding the pancreatic cyst. It provides real-time image with high resolution, and it can allow you to take some fluid for analysis. And but it has some disadvantage because it's operator dependent, and sampling error, and they may contaminate the specimen during the procedure. So these are the features that they are associated with high risk of malignance during endoscopic ultrasound. If you have a definitive neural node or main duct features suspicious of involvement, if the main duct is thickened or with some suspicious of infiltration, or if you took some cystic fluid and cytologically they are suspicious of malignance, these are patients who surgery are recommended. But a study that was conducted among those patients with branch duct interductal papillary mucinous neoplasia dissected specimen, among those patients with low-grade dysplasia, 3% were found to have neural node, but for those with high-grade dysplasia or carcinoma, 60% they have neural node. That's why a definitive node, if you find that on endoscopic ultrasound, is recommended those patients to undergo dissection. And these are endoscopic ultrasound, fine needle aspiration, cystic fluid analysis. You may be able to assess the carbohydrate, the CEA, which is most commonly used to distinguish between those mucinous and non-mucinous cysts. And the cutoff is above 192. But with this, it is difficult to distinguish between the interductal papillary mucinous and the mucinous cystic neoplasia, and also cannot differentiate between benign and malignant. Also, the serum amylase can be used to ascertain the mucinous. Another, with the cystic fluid, you can do cytology, but they have limited sensitivity because of the scant cellulite. And there have been some investigation about molecular analysis of the cystic fluid lesions. But with development currently, are investigating on the endoscopic ultrasound guided cystic ablation as an alternative to surgery, and it has been tested in some studies that it is safe and with minimal, and it is minimal invasive. But the recommendation is for those patients who are surgical candidates, and these are the agents that they are used. But these are the preferred candidates for cystic ablation. Patients who are high surgical risk, or those patients who refuse surgery with a cyst more than 2 centimeters, and it should be no communication with the main pancreatic duct. And these are the patients that they are ideal for cystic ablation. But these are the indications for resection. It is recommended all patients with main interductal papillary mucinous neoplasia and mucinous cystic neoplasia to and if they are fit for surgery, should undergo resection, because the risk of malignancy is high, up to 60%. And it can goes up to 92% for selected situation. And also patients with mucinous cystic neoplasia, surgery is indicated, especially for those patients with high stigmatous risk. But for those patients with mucinous cystic lesion less than 4 centimeters without neural nodule, they can be followed by imaging. But for branched duct IPM1, the mean frequency of malignancy is around 25%, and they usually occur in elderly patients, and the annual rate of malignancy is at around 2 to 3%. So this factor, they support conservative management and the follow-up. But for young age with cystic lesion more than 2 centimeters, might be candidate for resection. And the surgical option for this patient range from pancreatic duodenectomy or distal pancreatectomy, or for those with diffuse involvement of the pancreatic organ, you may go to do total pancreatectomy. And surveillance for those patients that they undergo surgical resection, there has been some little evidence, so the surveillance need to be individualized among those patients. And these are the investigations that they are recommended during follow-up, MRI with MRCP, and the endoscopic ultrasound. And for those patients with no high risk of stigmatas, the interval of screening within 3 to 6 months. But for mucinous cystic neoplasia, usually they are solitary, and the complete resection usually curative, so no need for post-surgery surveillance. But for IPM1 post-surgery, because sometimes they may persist because of branched duct IPM1, they may left unresected. And if the surgical margin, sometimes they have some residue of the IPM1, and some patients might develop new lesion. These are the patients that they are recommended to undergo 6 months surveillance interval. And this is the international consensus guideline for pancreatic cystic lesion management. Evaluation starts with assessing patients with high risk stigmatas of malignant. These are the patients with obstructive jaundice and enhanced solid component of the cyst, and the main pancreatic duct dilated more than 10 millimeters. So if you find this patient, they should undergo surgery, but if you have no this feature, you should assess features of Wilson. And if you have this patient, they should undergo endoscopic ultrasound and see whether they have indication for surgery. And if they have no indication to surgery, depending on the size of the cyst, these are the follow-up. For those with less than 1 centimeter, you have to do CT or MRI in 2 to 3 years. But for those cysts with 1 to 2 centimeter, you do CT, MRI at least 2-year interval, at 2-yearly interval. And for those cysts that they are more than 3 centimeter, you have to do close surveillance, alternating with MRI with endoscopic ultrasound every 3 to 6 months. And in 2012, there was a study that was done trying to look at the utility of this guideline. The standard and the international consensus guideline, they found that the international consensus guideline for this pancreatic cystic lesion has high positive predictive value of up to 62.5% if you compare it with the Sendai guideline, and a negative predictive value of almost 100 for those patients with low risk patients. So this being the end of this presentation.
Thank you so much, Dr. Lutege. Another round of applause to Dr. Lutege. So we are going to have a second presentation with the title Biliary Strictures, Endoscopist Perspective by Professor Elias Makur. So Professor Elias Makur and Professor Sameh Abdul Wahab will be the panelists for this session.
This phone is ringing.
It's ringing,
yeah? It is interesting to say that this kind of pathology may be in collaboration between the first one, radiologist and endoscopist. Sometimes surgeon, sometimes no. I think I changed the name of presentation to say tackling. I think tackling is TAC, resistant benign lesion structure. It is mean we must look about benign lesions of the common violence. It's okay? Yes. I don't have to repeat my social presentation. You are almost welcome in our city. Discuss about abnormal narrowing of the common bile duct. It may be due to intraductal benign mass or to injury from single acute event post-surgery or trauma, recurring conditions such as pancreatitis, chronic pancreatitis, or bile duct stones, or by chronic disease such as primary sclerosing cholangitis. What happens? Inflammatory response collagen deposition, fibrosis, and narrowing of the bile duct pneumo. The most common etiology for benign lesions, I ask just the common. We have less common. Post-surgical liver transplantation, cholecystectomy, bilioenteric anastomosis, inflammatory chronic pancreatitis, primary sclerosing cholangitis, or IgG4 cholangiopathy. More important, it is stenosis after cholecystectomy, after liver transplantation, and after chronic pancreatitis, less the other etiology. What is important when you have stenosis or benign structure of the common bile duct is to classify. You have to do classification. We have 3 classifications. More important for us endoscopists is BESMAT classification. We have a Strasbourg classification to surgery, complication, or Hanover classification. This is important to know a little bit about BESMAT classification for benign biliary structure, because your treatment depends, of course, from the location of the structure. We say class 1 if the lesions is more than 2 centimeters distal to hepatic confluence, 2 less than 2 centimeters distal to hepatic flexure, 3 if the stenosis is at the level of the hepatic confluence, 4 if you have involved right or left duct, and 5 the stenosis is extended into the left or the right hepatic branch duct. It is important to know this classification for benign biliary structure. Of course, clinical presentation may be varied depending upon the etiology, location within the biliary tree, and the degree of ductal narrowing. Accordingly, patients may be asymptomatic, have biochemical change in liver enzyme only, or present biliary colic with deep jaundice complicated by life-threatening cholangitis. Diagnosis, clinical history, it is important. Biology, radiologic finding, endoscopic finding, but what is important that I want to say, if you can have histological assessment with cytology or histopathology to exclude malignancy, is the better of our diagnosis and prognostic, of course. I don't have to ask about lab biology, but what is important is lab biology. Other thing than liver perturbation, you must also ask about the tumor marker CI 19.9 or CIA. It is important when you have benign lesion to be sure that we don't have malignancy. Of course, ultrasound to detect intra and extrahepatic ductal dilatation. It is less accuracy in defining etiology. CT scan and MRI is really better and superior to ultrasound to visualizing the distal common bile duct area. MRCP, it is important to see biliary dilatation, and we have around 97 to 100% of response. We can see the site of obstruction, detection and classification of chronic pancreatitis, and sometimes we have multifocal structure in case of primary cholangitis sclerosing that we cannot see it by CT scan. Of course, MRI, you can see the difference between benign lesions and malignant lesions. In case of benign lesions, The lesions is regular, symmetrical, and short segment narrowing. In case of malignant lesions, the lesions are irregular, asymmetrical, and longer length segment narrowing, more than 15 millimeters. Other thing, of course, using endoscopic ultrasound, it is important with AUS to see sometimes the small choledocholitis are around sensitivity 95%. Sometimes ultrasound is negative, MRCP is negative, with perturbation of test hepatic, the liver hepatic test, and the AUS is the best exam to see if in the common bile duct you have stones. And what is important also, you can do fine needle aspiration and biopsy. But I want to say the gold standard of imaging to diagnose biliary stricture stay by cholangiography. It is mean we have two possibilities to do cholangiography, by ERCP or by percutaneous in difficulty of ERCP to detect intra and extra hepatic biliary dilatation, stones, the site of stricture with high sensitivity and specificity. It is interesting, more interesting than the other exam said before. I want to say some studies suggest the presence of malignancy with prior negative sampling results. We do all the exam and we say it is benign lesions, but the studies say when you diagnose benign lesions, you must have a percentage of this lesion with malignant pathology. For this, we say actually that the gold standard, it's not the cholangiography, but the cholangioscopy. And with the cholangioscopy, we can do visualization of the stenosis, and we can do direct biopsy. If you see these slides, it is interesting. Sometimes we do ERCP, you have stenosis. What you do, bile aspiration, cytology, biliary stent, cytology, brush cytology, forceps biopsy, forceps plus brushing. And you see that the sensitivity of this technique, it is low, going from 27% of positive response to 55. It is mean we can miss malignant pathology when all our techniques say it is a benign pathology. For this, in this indeterminate structure, to improve diagnostic yield, we have objective technology are used. What we can use, cholangioscopy, we can do biopsy, we can do intraductal ultrasound, it is interesting, intraductal confocal endomicroscopy, FISH technique, OCT technique, DIA technique, spectroscopy technique. We have a lot of techniques to say it is benign or it is malignant, because our treatment depends if the patients have malignant pathology or benign pathology. Cholangioscopy, you go through the endoscope, we go through the common bile duct. You can see if you have inflammation, you can see that you have a polyp and malignant lesions. What is the technique that we can use it? Of course, we can use mother-baby scope. We can use the machine from Olympus, the spyglass. We discussed about the spyglass last time. We can use direct cholecystoscopy with a slim gastroscope. It is from Stor's machines that we can pass by a second endoscope through the channel of your duodenoscopy. And it is interesting because you must see direct your lesions. What we can see, you do a big sphincterotomy, that with this big sphincterotomy you can pass your baby scope or spyglass into the common bile duct. What we can do also, we can do biopsy, we can do ultrasound with this sphincterotomy, and we can do confocal laser endomicroscopy to detect early lesions into the common bile duct. This technique that I want just to mention, it is a technique to see if you have a cancer in the lesions, independently from the biopsy. The biopsy is the best exam to confirm the diagnostic. I don't want to pass a lot of time. It is experimental, but is interesting. Fish technique, OCT technique, spectroscopy technique, PIV, DIA technique. It is a technique developed in a research center that just with this technique you can say this lesion, it's maybe neoplastic lesions. The management and the treatment of these stenosis, of course, the gold standard, it is endoscopic treatment by ERCP or by percutaneous technique. What we can do with this benign structure, dilation or stenting, it is a question. What is important, dilation or stenting? If you do stenting, what is important? Use plastic stent or metallic stent. If you use plastic stent, it is interesting to use one plastic stent or multiple plastic stent, and is there a place for surgery for the surgeon. Of course, dilatation, it is the first exam to do. We can do dilatation by balloon or by Savary bougie. It's always interesting to do all endoscopic technique under using guide wire to reduce the risk of complication. And you must do it under endoscopic control and fluoroscopic control. The balloon dilatation, we can do it under endoscopic control and fluoroscopic control. Bougie dilatation is always doing under fluoroscopic control. The size of the dilator is guided by the size of the bile duct dilatation and the structure. Recommended are, you must do dilatation, you let your balloon or bougie more than 16 seconds. It is important to have a good success, and in using a balloon, you can insufflate the balloon till the structure waste disappear in fluoroscopy. It is important. But some structure is recurrent. You do dilatation, it is okay, and 1 month later you have perturbation of liver test. What we say, we do dilatation and we complete our treatment by plastic stent. Long-term outcome using plastic stent is equivalent or superior than surgical treatment in these cases, but we have, of course, a lower morbidity than surgical treatment. Did you use one stent or more than one stent? All the trials include that multiple stent, plastic stent, had higher clinical success and fewer adverse events. Like this, you can see how many stents you can put. One stent, here you have 1, 2, 3, 4, 5 stents for to treat stenosis in the common bile duct. The second question, what is better to use? What is better to use? Did you use plastic stent or metallic stent? In different prospective studies, with metallic stent, we have around 100% successful, 100% regression of cholestasis and cholangitis. 90% long-term success and less complication. It is interesting to say that metallic stent is better than multiple plastic stents. Which kind of stent we have to choose? It is important because of the choice of a stent in these cases, it is important. What I want to say that totally covered stent, totally covered, is indicated for the treatment of biliary benign stricture. But you have to pay attention. If the stenosis is around the Hiller place, if you put totally covered stent here, you have a problem for evacuation of the left part of the liver, and you risk to have cholangitis and septic problem. The second contraindication of totally covered stent, if your gallbladder is still here, if you put your totally covered stent here and you close your cystic channel, you must have complication like cholecystitis. It means totally covered stent must be used in the distal part of the common bile duct and not inside. What about uncovered metallic stent? These uncovered are unsuitable because we have ingrowth of the mucosa into the metallic part of the stent. What we can do, like in esophagus, we can put a stent in a stent. We put totally covered stent in non-covered stent to destroy the mucosa impacted in the metallic part of the stent, and we can remove the two stents together. If you see this, it is interesting, recommended if you have chronic pancreatitis dilatation, it is not indicated. Plastic stent, yes. Metallic stent, yes. Sclerosis, primary sclerosis, cholangitis, indication of dilatation and plastic stent, no indication of metallic stent. The liver, plastic stent and metallic stent, it's okay. And like this, you see what is the indication in case of pathology. This is to say also that metallic stent, the results is higher than one and multiple biliary stent. And if you like, just to say, this is a metallic stent, 1, 2, 3, 4, 5, 6, 7 stent inside the diameter of this metallic stent, and I say it is really better than plastic. Just to say, we can use percutaneous cholangiography. It may facilitate rendezvous ERCP technique. Dr. Abdel Wahab discussed this in his presentation. Can be used as primary means of structure management. What is the indication of PTC in case of failed ERCP? In case of prior surgery, it is mean altered anatomy preventing access of the major papilla, such as Roux-en-Y operation, that as I said in the morning, when you have gastric bypass, you have difficult to reach the papilla in case of surgery. Gastric outlet obstruction, prior duodenal stent. You have some really indication. Initial success of rate is around 70 to 90%. Post-liver transplantation structure resolution in 64% of case. Less results in case of sclerosing cholangitis. What is the complication of PTC? Hemophilia, cholangitis, bleeding, pleural, and fusion. If I have to compare ERCP with PTC, advantage of ERCP, it is internal, not external. Psychological acceptance by the patients. favorable because we can take a fluid and electrolyte if we need. PTC is easier in some cases when you have dilatation of the common bile duct and the biliary tree. It is more important in post-biliary injury, and we have lower risk of sepsis. When we have indication of surgery in case of failure after 12 to 24 months of conservative treatment. What's the new techniques in case of benign biliary stricture? We can use radiofrequency ablation, or we can use biodegradable stent. You have small studies that say that intraductal radiofrequency ablation, in case of refractory cases, it is maybe interesting to do it. And we have two small studies using biodegradable stent in this case. The first one is around 10 patients treated endoscopically, and after 6 months, no stent was visible, but the high risk of restenosis is here. And we have also a study about 13 patients who discuss the advantage of biodegradable stent in case of failed technique. Biliary benign stenosis might arise from a variety of etiology. Symptomatic patients may present with jaundice and or cholangitis, which are indication for treatment. Choledocoscopy for biopsy and for diagnostic is recommended actually to exclude neoplasm prior to treatment. And if you have to discuss the endoscopic treatment is the indication. And metallic stent is best than one or multiple plastic stents. Thank you.
Thank you very much, Professor Makul. Another round of applause to Professor Makul.
Thank you.
Okay, now we'll be moving to the same topic, but interventional radiology perspective. And this will be presented by Professor Samer Abdelwahab.
Samer Abdelwahab. Yes. Samer.
Samer.
Presentation. This one, percutaneous intervention, the plastic stent. This one, yes, and the I would like to see if the video is working. It's at the end. At the end. Nearly the last slide. Yes. Yes, it's working. So when we come to the video, I would like you to come and stand with me to make it work. You understand? Okay. Yes, it's okay. This is the last slide. Yes. Good afternoon, everybody. This is an extension of the lecture that Professor Dr. Ilya have given it to you a few minutes ago. It is the how to manage a case of obstructive jaundice, but from the percutaneous technique, not by the endoscopy, by the interventional radiology through the skin. Please. I want to tell them from the remote. Percutaneous transhepatic biliary drainage. It's either an external biliary drain, internal or internal, and both internal and external biliary drain, or it is percutaneous biliary stenting that we insert a stent inside the biliary duct, but percutaneously, not like the ERCP. When, as Professor Dr. Eli said, when ERCP fails, we never start by PTC because it's more harmful and more hazardous than ERCP. ERCP is more safe. In the ERCP, you go from the stomach to the duodenum, you cannulate the papilla, and you are inside the common bile duct. But in PTC, we do a hole, okay, it is a small snip in the skin, and then after that we puncture the capsule of the liver, and then we puncture the parenchyma of the liver until we reach the biliary tree. So ERCP, of course, is safer, but I think it's somewhat more difficult, but it is safer. That's the first indication. The second indication, as Professor Eli said, post-operatively, after surgery, alternating the normal GIT anatomy as biliary enteric anastomosis or Roux-en-Y, or in cases where the ERCP fails to reach the second part of the duodenum and lesions compressing the duodenum or something like that. So we first start by ERCP. But in the centers that have not the opportunity for ERCP, then we go for PTC. But first, ERCP. This is an ultrasound picture showing dilatation of intrahepatic biliary radicals. CT scan showing also dilatation of the biliary tree. This is CT scan showing mass in the unseen process of the pancreas, common bile duct, lower end of common bile duct. Ultrasound showing the portal vein and mass at the distal end of the common bile duct. Endosonography with this is the common bile duct and this is the portal vein, also mass at the distal end, externally not inside the common bile duct but at the distal end of the common bile duct. Of course, endosonography can help us to see whether this mass is invading the vascular structures, portal vein, superior mesenteric artery, superior mesenteric vein, because of surgery. If that mass is invading these structures, thus the surgeon is going to do nothing, and he will not be able to do Whipple's operation. Contraindication, bleeding tendency, contraindication to contrast media, bad general condition of the patient. These are relative contraindication. But for PTC, bad general condition, we can control the condition of the patient by letting our colleagues give him fluids, improve the bleeding tendency, and something like that. And even the contraindication to contrast media is not like that. Allergy is not like that when we inject the contrast media IV. Here we inject the contrast media in the biliary tree, so it has no much complications from the allergy and something like that. Technique, patient preparation. Of course, the patient is fasting. We give him umbrella of antibiotics before, under umbrella of antibiotics before, bleeding profile, CBC, liver function, renal function reduced. In cases of high creat, we must let our colleagues in the renal department to improve the condition, either by making him a dialysis before the PTC, or by giving him excessive fluids, and of course ECG and anesthesia consultation. At the start we were doing the PTC without general anesthesia, by local anesthesia, but now we prefer to do it by general anesthesia, even if we are going to do external only drainage. The patient lies in the supine position. We must localize the site of the puncture. We here localize the site of the puncture by both radiography to identify the recess of the pleura. So we don't puncture the angle of the pleura, the recess, pleural recess. We must puncture the pleura, the liver away from the pleural recess. And by ultrasound also to identify and to locate the better duct to be punctured, so that this duct is in continuity with the common bile duct, so that when I introduce my guide wire, it will pass to the common bile duct. And of course, even sterilization, even if patient has general anesthesia, we prefer to give him local anesthesia at the site of puncture. As I said, the biliary duct is chosen to be punctured by ultrasound. The idea is to be in direct continuity with the common hepatic and common bile duct. Intercostal approach, always we goes intercostally, so we must go through the anterior axillary line and take care from the pleural recess. Then we puncture the bile duct by an angiocast under guidance of ultrasound. We puncture the duct by angiocast guided by ultrasound into the dilated biliary tree. And then we continue after that the procedure under fluoroscopy. So I need an ultrasound machine and I need a fluoroscopic machine or X-ray machine. This is the only cholangiogram, PTC. This is our needle. We reached the biliary duct, we injected the dye. You can see the intrahepatic biliary radical dilatation, and this is the site of obstruction. I think here it is in the common hepatic duct. After that, the guide wire is inserted through the sheath and maneuvered to bypass the obstruction if possible. The sheath is then introduced and advanced as far as possible. Then the guide wire is replaced by more rigid guide wire. The guide wire, I use it in first, it's called the thermohydrophilic guide wire. This thermohydrophilic guide wire is like fishy wire that can goes within the duct like that. So I can maneuver it easily. But this guide wire, thermohydrophilic guide wire, is not stiff enough. It is very malleable, so it will not allow me to insert over it the stent or the external drain. So I must change it by a more rigid guide wire. Then after the thermo guide wire makes its duty, I replace it by another more stiff wire to complete my mission. If the obstruction is passed by, always our aim as a radiologist is to bypass the obstruction, not only to do an external drain. Because when I do for the patient an external drain, this is, as Professor Dr. Eli said, psychologically for the patient it's not good. It is a source of infection. It will be slipped after 3 weeks, 4 weeks, whatever, from the gauze and from the plaster here, infection. So always as an interventional radiology, I try to bypass the stricture. Because if I bypass the stricture, I can insert a stent. The problem is solved. But in cases, some cases, I couldn't bypass the stricture. So the solution is to put an external drain. This is a case. This is a case in which we can see here is cholangiogram done. Obstruction here at the upper end of the common hepatic duct or common bile duct. the guide wire is now passed through that stricture in the duodenum, and here's the full picture after insertion of a plastic biliary stent. Another case of cholangiocarcinoma, we here with clad skin tumor, we have here obstruction of the right main hepatic duct and obstruction here of the left main hepatic duct. They are not communicating with each other. So I passed a guide wire from the right and another guide wire from the left, and then after that balloon dilatation of the stricture, and then after that we inserted two metallic stents percutaneously, one from the right side and one from the left side. If the obstruction site could not be passed, and this is we must try to bypass the obstruction, not to make it easy. I'm going to insert an external drain for the patient. Take your time to pass the obstruction. If it does not pass, the insertion of external biliary drain is the choice. I have no choices because I couldn't inject that much dye in the biliary tree and leave the patient without doing for him any intervention. He will die because of cholangitis. So I must insert an external drain that goes to the outside and in a urinary bag to collect the bile out. In this case, as you see, I couldn't pass through the stricture, so I decided to do an external drain. This takes the bile to the outside to collect in a bag, urinary bladder bag to the outside. In some cases, an internal external biliary drain is applied. Which cases to apply an internal external drain? In biliary enteric anastomosis, we need to do multiple dilatation, multiple sessions of dilatation. At first, when I passes the stricture, I get a balloon, I think it's 8 millimeter or 10 millimeter in diameter, and do dilatation for the patient. And then after that, if I remove this, my instrument, after doing that dilatation, this one is not efficient. It will, the obstruction and the stricture, so it's a benign stricture, it will return once more within few months. So we decide to put an internal external drain. It will going to open that stricture and leave it for about 1 month. It is going to make a track, and I can come once more after 1 month or 3 weeks and do another session of balloon dilatation for the stricture, and this improves the results. So biliary enteric anastomosis, internal external biliary stenting is applied in cases of biliary enteric anastomosis. We can also apply biliary enteric internal external biliary stenting or internal external biliary drain when we decide to do for the patient a rendezvous technique that me and Professor Eli come. If he fails or the stricture is very tight, he cannot pass through the ERCP, then he told me, please go from the skin and introduce for me a caster in the duodenum, and I'm going to pick that, introduce for me a wire in the duodenum, and I'm going to pick that wire, and I'm going to insert a stent through the ERCP. So this is a rendezvous between me and Professor Eli. That's called rendezvous. Then, in cases of when the ERCP failed, I can come for the patient, do for him an internal external drain, leave him for 3 or 4 days in order to recover, in order to decrease the incidence of cholangitis, to improve the joint condition. And after 3 days, when that internal external drain is present, I'm going to pass the wire. Professor Eli is going to take the wire and insert the stent. This is an example for an internal external drain. I have passed the stricture. Instead of putting a stent, plastic stent, I put an internal external drain. This drain has holes here all over, holes all over the track, holes here, so it will take the bile from above the stricture and from below the stricture, and that's what's called internal external. Rendezvous, as I said, is the combination of percutaneous biliary approach and the insertion of biliary stent by ERCP. That was a patient who is done liver transplantation. You see the clips of the transplantation, failed the ERCP, because as you see, it is very bad structure. It is makes like the letter of S shape. The structure is here. This is the common bile duct. When the ERCP comes, he couldn't bypass that structure. I think it was easier for me to pass from that structure because when I put my catheter, the wire has only way to go like that. No other ways to pass. But in the ERCP, the wires will loop in this part. So I passed the wire like that, and this is the catheter. I passed the wire. The wire now is in the duodenum. They took from me by the ERCP machine, they took for me the wire, and then after that, from my role is now ended, the balloon is inserted through that wire from the ERCP for dilatation of that structure. And you see, after dilatation by balloon, we inserted the stent here, that is the ERCP, we inserted the stent. I removed my instruments, and this is the stent that has been inserted through the endoscope. The success of PTC is reported to be more than 95% in dilated biliary tree. Some cases they told for us, please come and do PTC for non-dilated system. It's very difficult, and its success ranges from 67 to 80%. Complication, hemorrhage, cholangitis, patient might go to shock, sepsis, peritonitis if I puncture the common bile duct directly. It is not allowed to puncture the common bile duct. I can only puncture the intrahepatic biliary radicals, but puncturing the common bile duct, I will be inside the peritone. So the bile will goes to the peritone, resulting in biliary peritonitis. This is a fatal condition. That's why we go through the liver panel. Injury to extrahepatic structures, abdominal, thoracic, and leakage. Of course, the use of ultrasound and the guidance by ultrasound decreases all these complications. I have a small video in about 5 minutes, if you allow me. Male patient, 47 years old, yellowish discoloration of sclera. He has clay stools, dark urine of 2 months duration, generalized itching. On examination, general examination, jaundice, abdominal examination, no abnormality detected. That was his labs. I think INR was okay, KDAP was okay, bilirubin is high, bilirubin, of course. Ultrasound CT scan revealed dilatation of intrahepatic biliary radicals in common bile duct with level obstruction at upper third of the common bile duct. External biliary drainage was performed with cholangiography to confirm the level obstruction is at the upper third of common bile duct with tapering of the common bile duct at level obstruction. Picture of was impressive of malignant obstructive jaundice. Yes, it worked. That's the trauma guide wire I told you. That's our catheter, which is inside the biliary tree. I'm going to use that wire. That wire, as I said, it's a malleable wire. I can direct it from the outside by small plastic piece called the cork device. You see, I'm going to pass the wire inside the catheter, and I'm going. That's it. That's I'm going to put, my assistant is going to put the torque device inside the guide wire, and we're going to play by the torque device like that in order to rotate the Turomo guide wire so it can pass through the stage. Because when we push the guide, Belia. In Egypt we called it Belia, but now we call it Belia. Give me Belia, please. Dr. Dori, who named it, You see, I'm rotating that guide wire from the outside. It's very important because when I push it like that, it will not pass through the stricture. I must deal with that stricture like a baby. Please, 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 until it passes. Oh, what happened? Sorry. I want the video once more. Sorry. This one? Yeah. Can move it for a few seconds if we can. Let's see first. If not, it's okay. Yeah, we can. Yes. Yes. And this is the most difficult thing in the procedure. In the whole procedure, this is the most difficult thing. It needs more patience, it needs skill, it needs orientation, it needs time, it needs everything. Because this is the main problem. If the guide wire passes, everything is okay. If it does not pass, it's okay. We are going to insert an external drainage. And for us as a radiologist, external drainage is not a good mission. This video is not a long video, it's only 5 or 6 minutes, so I'm telling to the audience that I move it from the outside like that by the failure or torque device. This is the most important step in the procedure. You see from the outside, I'm trying to manipulate the guide wire. Sometimes I insert the caster until the mouth of the stricture. Other times I remove the caster and let it there.
So going to and fro.
Yeah. Yes. Yes. As a child, you are, yes, like a child. Please, 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 until it passes.
Like a dancing waltz. One on the right, two on the left.
Yes. الشيك دايما بيقول حاجات شيك. الشيك is very elite, so he says something elite like dancing. But for me, I am a farmer, like a child. Of course, the malignant stricture is easier to pass than the post-transplant, because the post-transplant eye fibrosis. It is a benign fibrotic stricture. It is like the cement, like it's very hard. It's very hard, very hard. But the malignant stricture is a friable tissue, so the guide wire can pass through it easily. These all are trials. I think the guide wire is passed. I'm going to see it now. The stricture following is the guide wire. This is the guide wire, as you see, and okay. Now, when I pass that guide wire, I must inject contrast media to be sure that I am inside the duodenum. I think in one case I have done that step and I didn't inject the contrast media, and then please, Dr. Reda, come and take the wire, and then Dr. Reda put the wire, and we have seen that it was in the peritoneum. I have punctured the peritoneum.
And sometimes you are in the vessels.
My liver vessels are from the high up, not here, in the portal when I'm doing the puncture. But here I must inject contrast. You see, this is the typical appearance of the duodenum. I inject the contrast media. The contrast media goes freely inside the duodenum, and this is my caster. I have removed that guide wire. I'm going to insert another stiff wire. As you see, this is stiff, not like the other one. It's very stiff, hard guide wire. I'm going to put it in the duodenum so that I can do dilatation for the stricture. And then after that I insert this. I think this is the stiff, super stiff guide wire. We call it in Egypt amplant super stiff guide wire. I'm going to remove the catheter. I think we are going to apply the dilator now. Stent French dilator. That's why it is more dangerous than the ARCP. You notice I'm going to dilate the capsule of the liver by a large, huge dilator. This makes a great hole in the capsule of the liver and liver parenchyma because the dilator is very tough. Make dilatation. I mark the tip of the stent where I'm going to leave the tip of the stent. I'm introducing the dilator now. You see, it's the most important thing in that it does not be curved in that side. Take care, I'm taking care from the skin so that the dilator not be curved. It goes, yeah, when it curves, I think the procedure will fail. You see, this is the dilator. Yes, it passed safely through the stricture. I have removed the dilator and think I'm going to introduce it once more to make sure that it goes easily with me so that when I put the stent, it goes easy. Because if the stent, when I'm pushing it, is stuck, I don't know how to do what to do. Please, sir. Please, sir.
Yes. Yeah.
It stopped. I don't know why. Not for me. Okay. No, for the can move.
So it started from the beginning.
No, not to. We couldn't move it.
To the last one because
okay. I'm sorry. It doesn't work here. We are the next few seconds. We are going to notice that we have inserted the plastic stent inside the biliary tree. Okay. We have inserted the plastic stent inside the biliary tree. We have, as you see, we have removed the dilator, and then we pushed the stent. It was, and I was very anxious to mark its upper end so that its upper end is above the stricture and its lower end is inside the duodenum, and then take a photo, a picture, to see that it is working good with drainage of the bile from the biliary tree to the duodenum, and of course it was good, and we finished our mission with insertion a plastic stent. I think it was about 15 centimeters long, and it was 10 French plastic stent. And thank you so much.
Thank you so much, Professor Abdelwahab. Another round of applause. Thank you so much. Because we are running short of time, we'll have 3 to 5 minutes discussion.
Short questions, short answers.
Yes.
Short questions, short answers.
Yes, yes.
I don't have anything here.
I'd like to ask one short question.
Take this one, the demonstration.
Oh, okay. I'd like to ask for how long you keep plastic stent before you change it, or even you totally remove it. And what is the signs that everything is okay? I have to remove the stent now.
It is an interesting question. Normally, the stent can be in place between 1 month to 6 months. Maybe at 1 month, because the bile, it is like oil. It is mean you can have obstruction of the stent after 1 month. But you must leave it in place around 6 months if no jaundice, temperature, or pain. This is an indication to move the stent, to put another if it is necessary, if we discuss plastic stent.
So how long do you keep it when you remove it?
Look, we can go for benign lesions. I have a patient, I let the stent for 1, 2, 3 years. When you put one stent, the time to occlusion, it is small. If you put 4 stents, you can stay sometimes one year without obstruction. If you put metallic stent totally covered, 1 year you remove and you change for another if the obstruction is still in place. But I have a patient, I remove the stent and I put another stent.
I have one patient who forgot to come to me to remove a stent.
4 years.
For 5 years.
Yes.
With no obstruction. And
one
in a routine follow-up, he came to me for another complaint. I told him, what you have done with the stent? He said, no, I didn't done anything.
Still in place.
Yes, in place.
Yes, I have to say something interesting for our younger doctor. If you go by ERCP and you fail, you have a difficulty. Never inject contrast into the common bile duct. Never. Because if you inject contrast in the common bile duct and you cannot do a selective cannulation, you have to be sure that you have a septic cholangitis. Never injection. You will try always to work with your guide wire. If you can pass your guide wire into the common bile duct, you inject. Because if you pass your guide wire, like in radiology, primum, movum, you have to pass your guide wire. Work always with guide wire. No guide wire, no injection. Guide wire into the common bile duct, you inject because you know you can do dilatation and put a stent. Now, with some cases that you discuss that you pass through PTC, you have to think that I want to say by experience. Sometimes with PTC he cannot pass the guide wire through the stenosis. If you have very experimented doctor doing AUS, he can do a drainage through gastric wall, puncture through the stomach wall into the left bile duct, and he can put a stent between the stomach and between the duodenum. The third thing, I think it is better when you have a difficulty to do rendezvous technique. Why? Because yourself, when you do dilatation and you pass your big stent, a lot of patient has a leakage into the function of liver, and we can have chemical peritonitis. For this, I think we can, if you can pass the guide wire, we can work together and put ourselves the stent or the drainage.
Yes, of course, I prefer that. I told you, Professor Butreni, that I don't prefer to do to insert the bigger stent through the
PTC because of I do a hole in the capsule of the liver, I injure the parenchyma of the liver, I do puncture to the miliary. So the insertion of a stent or something or more manipulation is much more dangerous than only passing the wire.
Yes.
So if I have around who it is now better, I pass the guide wire and then the endoscopist take the wire and insert his stent. But in some cases, the endoscopists say, no, I don't want to do this case once more, please manage it by yourself. By ERSP, I would like also to tell the audience that never to inject contrast media except when you are sure that you are inside the common bile.
Yes, it's second, same comment.
Yeah.
Never inject common bile duct, never inject Wirsung. Go with guide wire to be sure that you are into the common bile duct and you inject.
Yes.
If not, never you inject.
If the wire goes in front of the spine, so you are in the pancreatic. The common bile duct goes upwards to the right quadrant, but the pancreatic duct goes to the over the spine. So don't inject contrast media if the guide wire or your catheter is in front of the spine, because this is in the way of the pancreatic.
Of course, just one thing, when you have difficulty to cannulate common bile duct, because it's easier for the guide wire to go into the Wirsung, the anatomy. Go into the Wirsung. When you have your guide wire into the Wirsung, let it into the Wirsung, come back with your sphincterotomy and pass a second time, and you try to push a second guide wire into the common bile duct. It is the technique double guide wire. I published this technique a lot of time ago. You do what we say double guide wire technique. You have your guide wire into the Wirsung. When you have into the Wirsung, you close the papilla going from the Wirsung, and it's easier for you to go into the common bile duct. Easier. Never mind, you have difficulty, you have your guide wire into the Wirsung, you have a difficulty to go into the common bile duct, and you must do pre-cut. If you do pre-cut, always protect your Wirsung with a small plastic stent to reduce the risk of pancreatitis. And in the two cases, never inject if you are not sure. Never inject into the Wirsung because you increase the risk of pancreatitis. Inject when you are sure into the common bile duct. And never inject to see where is the direction of the common bile duct. If the dye, because you are working not sterile, yeah. If you have injection into the common bile duct without a drainage, it is septic shock, sure septic shock. If there's some question for Doctor about complication, no. Colorectal, no. Yes, Doctor? More? Yes, is there some question to finish our discussion? Yes, please.
Thank you. Yeah, I just wanted to ask about your opinion about the benign strictures. In some cases, we probably make a mistake from the imaging. We think this is a benign stricture. We do ERSP, you put in a plastic stent, and later on you find out this is actually malignant. When you remove the stent, and then immediately you have obstruction, and on further imaging you find this is actually malignant. So I was thinking, what are your indications for taking cytology or biopsies? Is it in all patients that are probably benign but non-local? What are your criteria for taking biopsies or cytology? Do you prefer the age, if they are elderly or not? Yeah, so I need your guidance.
That's what I put like slide, brushing, blindly biopsy. I try to take blindly biopsy. Cytology, brushing, blindly biopsy. The result it's around only 50, 16, 27. Brushing, it is a cytology, it's not biopsy. What I said in this presentation and what is important, it is if we can do cholecystoscopy. It's difficult, I know, the material is not here, but we have a message to pass and say what we have to do. Can I do it or cannot I do it? And in my department, some techniques we cannot do it. The best is the biopsy, going inside. Maybe sometimes you have small stones and you say it is cholecystoscopy. It's actually the gold standard with biopsy to confirm malign or benign lesions.
Thank you so much, Professor Makura and the team. I'm sorry we are not having time, Dr. Swallow. We'll give you we can give you at least 2 minutes when you come back. But as for now, we are supposed to go for lunch. But before we go for lunch, I'll welcome the pharmaceutical representatives from different pharmaceuticals. And we start with Mega OK, and each one will only use 2 minutes. Only 2 minutes. Can we start with Mega OK?
Good afternoon to all the doctors inside. I'm a pharmaceutical representative from Mega Care. Mega Care is globally in the most of 50 countries, but our plants are based in Thailand and Australia, but we are operating in more than 50 countries, including Tanzania. And we are the leading company producing soft gel capsules. Among of the soft gel capsules in your department, I think most of them you all know. We have the Volume 40, a hepatotonic product for nourishment of the liver, but also we have a someprazole injection called the Zastin, and also we have Nomagat, a probiotic, and also we have ursodeoxycholic acid, 250 milligrams. So I congratulate you all because most of the products are being spoken on your slides here, though indirect, but the molecules we all have. Thank you so much and congratulations for this AGM.
Thank you so much. Representative from Mega Care, Sun Pharma, please. Do we have someone from Sun Pharma? They're not around. You can take your place.
Very good afternoon, esteemed delegates. And first of all, I would like to thank Dr. Kazi and the Gastro Department of Muhimbili Hospital to give us this opportunity to be here with you today. And let me introduce myself. I'm Gurvinder Singh. I represent IPCA Laboratories. That's a pharmaceutical company which is based in India. And we are operational in Tanzania for the past now more than 15 years. And for the gastro specialty, today we have the product which, like you've already spoken about this product, the role of prebiotics and probiotic in the management of constipation. So we have introduced this product, now it's more than 2 years in Tanzania. That is our NutriFiber, the brand of our product which is meant for the management of chronic constipation. Basically this is a prebiotic and it has 3 basic dietary fibers. It has inulin, which has been taken from the chicory roots. It has partially hydrolyzed guar gum, which is taken from the plant guar, and it has resistant maltodextrin from the cornstarch. Now the role of these fibers, they are soluble and fermentable fibers, and due to fermentation they produce short and fatty acids, and it helps to generate the gut microbiota. And this product offers because of production of short and fatty acids, it helps to generate gut microbiota such as bacteroids, pneumococci, those type of healthy gut health. And this product is available in a pack of 200 grams, and it is to be taken like there is a scoop inside. Dose is 4.5 grams on daily basis. Initially, you can start with twice a day, then you can maintain with once a day. So, looking forward to the department for the support of our Nutrify. Thank you so much.
Thank you so much. Abacare, please. One representative from Abacare, 2 minutes.
Good afternoon, all of you. Nice to meet you all. Dr. Tades yesterday has already spoken a lot about the novel product of tenofovir, which is a potent inhibitor of HPV replication at low dose with better renal and bone with safety profile if you compare with the TDF. So you may ask yourself, doctors, that where will it be available? Tafnat will be available or is available in Tanzania right now, and we are selling at 45,000, which is equal to 19 USD. This is the package, doctor. Also, another thing, we have a range of probiotic range of products which we have divided according to different indications. And our combination are the symbiotic formula, which are having both pre and probiotics. And we have so many, we can just highlight quickly. We have this advanced rescue, which has got 10 strains of probiotics, bifidobacterial, lactobacilli, and lactococci, which is 6 billion colon forming units. These are indicated for all the patients who are in antibiotic treatment for restoration of gut flora, for the patients who are having lactose intolerance, also for all who are in post-operative stage. Our products are 100% vegetarian, non-GMO, and about the quality, doctors, these are manufactured from Canada. We have another product which is colon care, which is has got 6 strains, and this is indicated for chronic constipation and bloating. This is colon care. And our rescue is Saccharomyces boulardii. Saccharomyces boulardii is indicated for the patients who are having antibiotic-associated diarrhea. And all the products are, the dosage is once in a day for 30 days dose, and it is preferably to be used in the morning before breakfast. And if your patient will be in antibiotic treatment, then should differentiate at least 2 to 3 hours before or after antibiotic medication. And the last one is our Prosin doctors, which is 4-in-1. Has got an ORS, probiotic, zinc, and as well as vitamin C, which is given in cases of dehydration. We have put 3 strains of probiotics here, which is very good, and we have put 4-in-1, which will ensure also the compliance to your patients. Doctors, this has also got an improved flavor of orange, so this is very nice for your patients. It's available in all Tanzania places, including Muhimbili National Hospital right now. It's available, doctors. So for your prescription, thank you very much.
Thank you so much. Abacare, IPCA, IPCA, Mora.
Yeah, definitely, sir. Will not take much time. First of all, I would like to say thanks to all the delegates, Muhimbili Hospital, especially Dr. Pazi, for giving us the opportunity to present our product in front of you. As sir, madam said, will not take much time, sir. There are 2 products to highlight basically. One is sucralfate and sucralfate ojal. Sucralfate contains sucralfate, 1 gram per 10 ml, and sucralfate ojal contains sucralfate with oxylogen combination. This molecule is very old in the market. It's not a new molecule, but the results which we are getting till now with the sucralfate, it's fabulous. It's neither the acid reducer nor the antacid. but it is working as a both, as an antacid as well as the acid reducer. Basically, the category of sucralfate is cytoprotective. As I said, it's working as an antacid as well as acid reducer. We have the scientific data to support it, as it is increasing the level of bicarbonate and as well as increasing the level of prostaglandin in the body. So ultimately, it neutralizes the acid as well as increases the mucus level in the.
It acts locally, systemically.
Yeah.
It acts locally. You said that it raises the prostaglandins in the body.
Indirectly, sir, not directly. It increases the prostaglandins for sure. Sir, I can share the scientific data with you for that matter. Okay, so fine. So this is about sucralfate. Its indications are like peptic ulcer, gastric ulcer, duodenal ulcer, any kind of gastritis. We can use it. Oxytocin work as a local anesthetic agent, sir. So when there is a pain with gastric ulcer, we have to give sucralfate over here. In this country, sir, affordability is a major concern. So we have taken care of it in the account, and they have kept the price of sucralfate only 5,000 shillings, and sucralfate O-gel 3,500 shillings. Yeah, that's the price. And the company from where we are importing the sucralfate, it's Force India, which has already got the UK MHRA and USFDA approval. Thank you. Thank you. Thank you.
Thank you so much. Any remaining? So before going for our lunch, we'll have one last session, not academic session. We're having prize and our certificates giving session, and may I humbly welcome Professor Reda, the President of Ahmad, and Professor and Dr. Komba, our President of Tigers in Tanzania. So please. Alpha and Brighton, can you help us with the takeoff?
build up to someone video some flash.
Good afternoon, everyone. This is for Dr. Eduardo Komba, for attendance. Picture, please. We need a picture. We need pictures. Eyes video on the sword. Eyes video on the sword. Senor, Dr. Masura Mwanasari, aje. Come on here. Dr. Paz afuatie. Dr. Jembe. Jembe here. Okay, Dr. Mwerangi Alexander. Dr. Alexander. Tuzo. Dr. Richard Ajandaye. Dr. Tuzo. Dr. Richard Ajandaye. Dr. Daniel Muganis Ajandaye. Dr.
Richard. Moja. Dr. Sange Ndai. Dr. Eva Jandai. Na Dr. Majingi awe standing by. Dr. Amunga Meda Jandai. Dr. Harriet Filbert Yera, gastroenterologist from Mwanza, 1,000 kilometers from here. Mwanza, 1,000 kilometers from here.
1,200.
And the swallow prepared. Is our MC. Dr. Mutege, get prepared. Dr. Catherine Martin Mtui. Dr. Ahmad Kapinga. Ramadhani Mfinanga ajiandae. Dr. Ramadhani Mfinanga, Dr. James Zakaria, stand up, please, if you are here. Alpha Teresia Kita Masangama. These are guys of our registration. Brighton Katibu Mtenga. There's an MD5 student, they complete their undergrad. They help us in the registration. Annabelle Mwidini. So these are professors. Professor Hala El-Wakil. This is the wife of Professor Hal, Professor El-Wakil. Yeah, yeah, on behalf of yes. Professor Samir Abdul Wahab.
بس بص لي على
سامح
بص لي على سامح
بروفيسور محمد كمال
تعال صورني بقى سامح
بروفيسور الياس مخور Professor Medhati Al-Sahab. Professor Medhati, Major General Professor.
I think it's set.
Yeah.
The pleasure, you can take a picture. Yeah. Thank you.
We have Ambassador Shireen.
Ambassador,
yes. Yes, Ambassador Shireen. We have Professor Abdul Majid Qasim. He's not with us today.
He left, I think.
Yeah, I understand. Professor Mohammed Direda Al-Wakil,
yes, I think
the president of Amage. So we have pharmaceutical companies, starting with IPCA. IPCA.
You didn't show representative.
Thank you very much.
Yes, Avacare Health Tanzania. Yeah, we have a certificate for Arab Fund for Technical Assistance to African countries.
This is for Madam Shekhi.
Yeah.
Thank you.
Yeah, more Pharmaceutical Limited. More. Yes. Yeah, Sun Pharma.
Thank you, sir. Thank you.
Sun Pharma.
Sun Pharma.
The outside, I don't know why they're coming in. Yes, certificate from Mwimbi National Hospital. I don't know. Dr. Atuzo, please take it on behalf of Executive Director. Yeah, I know it. But it's very good. Be with us. Yes. Yes, Muhas.
FUMAS, Dr. Komba can take on behalf of FUMAS, on behalf of Vice Chancellor. Okay, Mega weekend. Yes.
Thank you.
Thank you very much. Yeah, that marks the end of the...
This is the end.
Yes.
Thank you so much.
Thank you. So we need to have a picture.
Because the room is because of time, I think we have صورة محمد صورة كده
Yes.
Okay.
This is one of the history. Thank you very much.
Thank you so much. Thank you. So I should take now this opportunity really to thank everyone for participation, starting with the delegates from Amaji, led by Professor Reda. Job since your arrival last week, starting with hands-on training, then you have come to this conference. Very good contribution in teaching. We really thank you so much. Thank you to all other members. Thanks to the pharmaceutical companies for really giving us a upper hand, and we have really participated very well. And thanks to our secretariat led by our students. They have now just graduated. I should not forget our MC, Dr. Harriet. You have done a great job. We do not have much time. I think I should call this meeting to the closure. Our visitors, delegates from Amaje, will be traveling, I think tonight.
Yes.
Yes, we really wish you a very good flight back home. Our greetings to our colleagues at your homes. Yes. And we wish that you will come again, maybe next year, if we give an invitation. So on behalf of the President of TAGIS, we thank you so much. Right now we'll be going for our lunch. We have been late and they want to close. And once we finish our lunch, I think we will allow our visitors, professors, to go and take a rest before your flight. But we will continue with our annual general meeting right here. So until another time, we should close this. Maybe a few words from Professor. Thank you, Professor Dr. Komba. Thank you, Dr. Bazi. Thank you, Dr. Masolwa. It was a great pleasure for us to be here with you. We found a very high standard for the scientific content of this conference. I congratulate you for arranging for such an international standard conference, and I hope to keep so. We enjoyed a lot for being here in Dar es Salaam, and we went to Zanzibar. We have a crew there, we have a crew safari there. We enjoyed very much. I hope to come again and again each year. Thank you so much. Let's go for lunch. Dr. Komba.
Yes.